Good afternoon, and thank you everyone for joining us today. I, Ankit Dogra, along with my teammates Dr. Deepika Chhabra and Ms. Ramit Saxena from Medical Services Jagsonpal Pharmaceuticals Ltd, are delighted to welcome you all to the two-day academic conference Abhilasha, Saving Mothers, organized with a very noble intent to reduce maternal morbidity and mortality by Haryana Associations of Obstetricians and Gynecologists, powered by Jagsonpal Pharmaceuticals Ltd, makers of LycoRed soft gel capsules of lycopene, zinc, and selenium, EndoReg dienogest 2 mg tablets for the medical management of endometriosis and endometriosis-associated pelvic pain. We thank Haryana Association of Obstetricians and Gynecologists for taking Jagsonpal Pharmaceuticals Ltd as the digital partner for the program. A warm and hearty welcome to all the esteemed faculty members and attendees. Dear attendees, if you have any questions, suggestions, and clarifications, please post them in the Q&A and chat box. Please note this webinar is streaming live on the Facebook and the link is shared in the chat box. Also note, for the future reference, we will upload this webinar on Jagsonpal Medical Insights, our YouTube channel. Now, let us start the program with the blessings of Almighty. Now we welcome and request the organizing chairperson of the conference, Dr. Ragini Agrawal ma'am, Founder, President, HARObGyn, to kindly take the proceedings further. Over to you, ma'am.
With the blessing of God, we'll start our program. Very good afternoon to all of you who has joined and the esteemed faculty who has taken time to be with us and to teach all of us for a very, very important part of the prevention of the maternal mortality, that is PPH, eclampsia, and maternal collapse. And the faculty which we have chosen are the national faculty, and their immense experience in the field of prevention of the maternal mortality. So I welcome you all again on this board. When the Haryana OB/GYN was formed, we have in our mind three major projects. One is Abhilasha, to reduce the maternal mortality in the state of Haryana, to make our doctors in the Haryana medico-legally efficient, and to speak in one language medically. We are trying, and slowly, one baby step is going towards our aim. And under that banner of the Abhilasha, Saving Mothers, today's program has launched. Our second program, UDAN, is for the adolescent health, and we will come again with a 2 days big conference in August. For UDAN, we had our last conference in 2020. It was an international conference, and even the WHO has participated. And our third program, Mukti. It is a Mukti from the unwanted pregnancy, Mukti from the STI, Mukti from the cancer. So for that, again, after 3 months, we will come with a 2 days program under the non-communicable disease to prevent infections and the non-communicable disease in the women. So with this word, I introduce my right, left hand and backbone of who are the conveners of this conference. Dr. Jyoti Malik, the beauty with the brain, everybody knows her. And she is the director JGIMS and the secretary HARObGyn. Not only this, she is a renowned infertility specialist, and she is going to be the chairperson Haryana SR also. Next slide. And Dr. Saroj Kumar, she is, we call Annapurna. She is the treasurer of the society and always there to help. Whatever program I bring, the execution is done by Dr. Saroj Kumar. She is a practicing gynecologist in Gurgaon. And at present, she is the secretary of the Gurgaon IMS, and she is the past secretary of Gurgaon OBGYN Society. Dr. Promila Malik, the Abhilasha and the reduction of the maternal mortality in the state is a dream of Promila, a very close friend of mine, a dedicated obstetrician who does all the delivery normally as far as possible. Even I say her, why you are taking so much of the risk? But she's always with the patient, and she's the past president of GOX, senior consultant and obstetrician and gynecologist. Now, over to now I will start the first session of the program. It is for the PPH. We all know that the postpartum hemorrhage is a nightmare of an obstetrician. When it occurs, are we really able to stop it? It is always in our mind. We should not forget the first golden hour. And for that PPH, I have chosen two persons who are totally working in a grassroots level. None other than Dr. Sadhna from Gorakhpur, and Dr. Sadhna Gupta is really, I call her a grassroots worker. We all know that Gorakhpur is from a eastern UP, and it's the biggest city in the eastern UP, and the drainage from all around. Her practice is more or less with the rural India, where even the patient comes in a bad shape also. I'm seeing Dr. Sadhna working for last almost, I can say, 30 years. And she is the representative of the SAFOG, FOGSI also, and the vice president of FOGSI. Now she is contesting for the president post of the FOGSI. All the best wishes, Dr. Sadhna. And the second person is none other than our own PPS lady of the North, Dr. Shashi Lata Kabra from DDU, who is her motto of the life that every gynecologist should know how to ligate internal IVF. And I think as a obstetrician, we all agree with her that internal IVF ligation can save many, many uterus and the many, many lives. And every doctor should know we cannot get another surgeon or anybody else to help us at that time of the PPH. So I welcome you, Dr. Sadhna and Dr. Shashi, and hand over the dais to you for the workshop. Over to you.
Thank you, Dr. Ragini, and thank you all office bearers of HARObGyn to give this unique opportunity. Then we are doing PPH drills on the virtual platform, and myself and Dr. Shashi will be going along straight away to the practical session, what is needed, because we know much more about theories, but it is actually system which is important, that the person should take a lead. We must have a team for the lead, and we must have system in readily in our place. It is like a thunderbolt can kill the patient in 1.5 hours and can kill your career as well, your reputation, so many repercussions. So we will go straight away without like having, it is a clear issue to be handled earthily, and we will go straight away to our videos. And so,
thank you, Ragini ma'am and team Abhilasha for having us here.
So this is the PPH box, which should be there in every labor room and every operation theater also. What does it have and why? What is its importance? Because whenever the patient is bleeding, you have all the necessary things for resuscitation and first line measure in a one go, and you don't have to send the patient's relative or send the nurses to take one thing by one thing. So what is it? I will just enumerate. It is 2 intracare. It should be the green color or the gray color. You can keep one pink color also, because sometimes the patient is collapsed and it is difficult to put the bigger catheter. At the same time, we must have all the things for that benefits ready, and with the two IV infusion sets. So 2 benefits, 2 intracare, and 2 IV set as well as a blood transfusion set. We must have the vials for the blood group and crossmatch, as well as for the we must have the plain wire, EDT wire, and the citrated wire for investigation as well as for the cross match. Oxygen face mask is the most important thing because whenever the patient needs, the patient needs oxygen irrespective of vitals. Make sure that your T2 oxygen cylinder is hanged by a ball piece on the wall trolley so that it doesn't get lost. Now, with the resuscitated feature, which is the 2 IV, intracranial, blood transfusion set, oxygen face mask, we must have all the drugs for initial oxidosic agent and which are injections. Give me Manila, give me. So these are all injections which are kept at the room temperature and the injection which are kept in the fridge. What are in the injection? It is methylergometrin, tranexamic acid. You can keep heat stable carbitocin in your box. You must have 2 or 3 vasopressors like Epcordine, Wtex, and the dopamine also in case you need it. You must have the Follis catheter with Europipe, one for the catheterization of the patient and one for the possibility of the balloon uterine tamponade, which we will discuss later. And all the necessary things like condom, like suture material in the same box. Misoprostol drug always to be kept 3 or 4 tablets, and I suggest that you always keep 1 or 2 things extra because whenever the patient is bleeding, there is a little bit chaos and everybody is anxious and sometimes the things get lost or fall off. A local infos kit if you need any hemostatic packing, and beside this a small Caesar. So this is the PPH box, and I will say that you please always look at least twice a week or daily by the senior sister that all things are in place and they are not getting used in the night or any emergency and they are being refilled. Also check the expiry date because few drugs are not being used. There is no issue in discarding them because you must have the drug when you want it, and if you don't have the drug, then it is a real issue. So one readiness is the PPH box, which should be ready and which should be handy. So just to again enumerate that what we have average in time. Now, patient has undergone vaginal delivery or cesarean section and yes, madam. Please always look at least twice a week or daily. What do you need first of all? The intracap, and it should be always green or the gray intracap for the rapid infusion that tone the drug in sequential manner. So it is today we have got the carbidocin, which can be heat labile as well as the heat stable. So heat labile and keep another Follis catheter radiant profile and liver and renal every day. And as a senior obstetrician, you must also check at least twice a week. Thank you. So now we are ready with our all PPH books, drugs, and the patients. And the nurses are quite confident that they can identify postpartum hemorrhage in time. Now, patient has undergone vaginal delivery or cesarean section and she is bleeding. What to do in the coordinated fashion? So, bring first PPH box and what do you need first of all? The intracap. And it should be always green or the gray intracap for the rapid infusion of the fluid. At the same time, when you are inserting the intracap, take the sample for the blood group cross matching as well as for the hemoglobin profile, coagulation profile, and liver and renal kidney function test. So you must have the plain wire, EDT wire, and the citrated wire in this PPH box. You have Benefix, you have 2 IV infusion sets, and make sure that you infuse around 3 times of the blood which you are estimating the patient has lost. So if it is around 1000 ml, infuse 3 liters of fluid in next 1 hour. So you should be fast and always ready to have the backup of all blood components. So this is the beauty of PPH box, and you have everything on the hand. At the same time, you always catheter the patient. And why this catheterization is important? Because you can assess the tone of uterus. You can see what amount of urine is there any hematuria in a suspected concealed uterine rupture or any other complication, and keep another Colles catheter ready in case uterine balloon tympanod is needed. So that this is the beauty and this is the importance of postpartum hemorrhage box, that you have all the things ready in the next 10 minutes and no precious time is lost in the resuscitation of the patient. At the same time, oxygen by face mask, this is also very, very important, and irrespective of the marked severity of the hemorrhage, you must apply 10 to 12 liter or 8 to 10 liter of oxygen by face mask. So this is the first line resuscitation. Secondly, if you think that this is the atonic hemorrhage, then you must have all the drugs necessary which is available and all the drugs in sequential manner. So it is today we have got the carbidocin, which can be heat labile as well as the heat stable. So heat labile oxycarbidocin to be kept in the fridge, as well as the all oxytocin and the prostaglandin F2 alpha. So it is 10 unit oxytocin intramuscular as the active management of third stage of labor, then 20 to 40 unit oxytocin in a drip, or carbidocin 100 microgram in a 1 minute. If you use carbidocin in 1 minute, then there is no need for further oxytocin, but there is need for prostaglandin F2 alpha, misoprostol, as well as the methyl ergometry. We have to be ensured that there is no contraindication to methyl ergometry like anemia, like high blood pressure, and for prostaglandin F2 alpha, like patient is not having any asthma or glaucoma. So the review of the patient in management is also very, very important. So this is about the medical management and the aggressive resuscitation, and always it is ABC, that is airway, breathing and circulation. Though in PPH the circulation part is very, very important, as 70% of all PPH is due to atonic, then we must have all the drugs which are good oxytocin. Besides this, tranexamic acid should be available in this box, so that tranexamic acid always to be used in initial phase. Now, after daily readiness, we have second thing which is of utmost importance, that our every junior doctor and every nurse who is taking the labor room patients, they must know to identify postpartum hemorrhage when it is crossing the upper limit of bleeding, which is considered normal. For this, the visual estimation of blood loss is of key importance, because that is the thing which we do practice in all settings. So give few clear instruction to your resident doctor and staff that what is the time when you must call the senior obstetrician, because it is golden hour, and if we miss by the late identification of PPH and we start resuscitation and management after 1 hour, then the chances of criticality is too high. So give few clear instructions. If the patient has soaked 5 pads in a row, if she is constantly bleeding, if she has passed suddenly a big clot, and the patient's heart rate is going by around 30%, and her blood pressure is dropping by 30, then it is the time that all red alert team and the response team should be in action, and the senior obstetrician must come into the scene to take the lead. So these are few pictures which we are taking it, and we will say that when we have a clear picture in our mind that how much blood loss is there. So Dr. Manila, so this pad has been soaked by a woman. So it is how much around it is a blood loss? It is around 25 ml. And this much is it soaked fully, partially? It is around 50 ml of blood. 50 ml. And when this you have put a moderate size pad, it is fully soaked in around 15 minutes. So what will be your interpretation? So it will be around 100 ml. And you have put a big LAQSHYA pad, and it is soaked within 10 minutes. So what is your blood level is 300 ml. And patient has passed suddenly a big clot and the blood is on the whole of the bed. How much amount of this blood loss is? It will be around 500 ml. So it should be, and if the blood is on the bed, then it is around 1000 ml, and then at the same time you will start resuscitation method and you call all senior obstetrician and senior nurse for it. We can use Devdas bag if it is available. You can put under the buttock, and there is a mark on it also, but it is not commercially available. So be ready with this visual estimation. Do drills in your setup so that the people know that what is their PPH, when we should identify PPH and take all necessary measures. Very, very fast on the board stage. Balloon tamponade can be prepared in various ways. We can prepare as a condom uterine tamponade. If your facilities can afford, then the battery balloon, in which it is a ready-made balloon. But for most of the settings, we don't have that ready-made balloon, which costs a lot, and the many facilities cannot afford to keep it. So let us understand that how we make this life-saving tamponade in a few minutes. Take this one Follis catheter which was in your PPH box. Take one condom and keep it always in PPH box and put it around 2/3 of the distance for the Follis catheter. You always need an assistant when it is around 2/3 of the catheter. Insert, hold it, hold it, and you ligate it with any sterile cadget or pad, whatever it is available. So make it very airtight, is ligation of this pad, and then you connect it and see that it is inflating or not. So connect it with the 500 ml normal saline, and first you check that it is airtight system or not. Open it, remove scoping cover. So you think that when you are connected and you see that it is working and the balloon is inflating, you see that it is inflating, it is not leaking. So our system is working. Now I will insert this uterine tamponade in the patient's uterus. And how we do it? Stop the cavity, then we will start refilling the bulb, speculum, vaginal retractor. So we are demonstrating on the monitor. Hold it, assistant will hold it, and you will hold the anterior report cervix with the anterior this spine holding faucet. Then either you put it, you can give it with the report cervix, and we will put between index and our thumb, we will insert it to the uterine cavity. And when it is uterine cavity, when it is fixed into the uterine cavity, then we will start refilling the bulb, the uterine tamponade. Open the telescope. It should be 500 ml normal saline and it should be warm at the room temperature. When it is filled, you can feel the bulb. You can feel this bulb on the per abdominal hand. It should be very careful that your bulb should be visible. When it is properly inflated, it should be visible around external os, around internal os and the external os, and you can feel on the per abdominal palpation. When it is there, and then you will see that the bleeding is being stopped and not. This is very important in PPH management, that every measure has got its own efficacy, and according to idiopathogenesis, any measure can be effective or not effective. If your bleeding is stopped, then you put the catheter, you will remove this 500 ml, it is done. Then you will put this rest of the catheter in vagina and give the tight package into the vagina. So you pack and you must have the tight packing into the vagina. Post-operative antibiotics as well as the oxytocic agent are necessary. Now the second question is when to remove this uterine tissue. If the patient is settled, then you can remove it after 12 to 24 hours. It is always better that you deflate it in the daytime so that every senior person is there if there is a rebound bleeding on the postpartum hemorrhage. How do we remove? We will remove the vaginal bag and we will deflate. Give me a syringe, please and always remove first 50 ml. You have inserted 500 ml, so first you remove 55 around 50 ml, and then you see that the patient is having any bleeding or not. If it is not bleeding, then you can deflate within 20 minutes or 30 minutes slowly by the gradual deflation and a close watch onto the patient's bleeding and the hemodynamic status. If you think that after deflating patient is having rebound bleeding, then you again reinsert the saline and keep the catheter for further 6 to 8 hours. So it is a very easy, very effective way, and all the professional body recommends as well as the experience recommend that the uterine lymph node has got a special place between the laparotomy and between the other surgical measures which may be more invasive and require more anesthesia, and it is effective in around 80 to 90% of the atonic postpartum hemorrhage cases because it has the hemostatic pressure. It actually presses the venous blood as well as the arterial blood, and there are many action by which it stops bleeding. Another very, very effective method to deal with any sort of postpartum hemorrhage when the abdomen is open, or either you are in cesarean section or you have opened the abdomen for surgical measure. That is the uterine artery and ovarian artery devascularization. Whether it is a placental bed bleeding or it is adherent placenta or it is atonic, this simple step actually reduces the bleeding in all cases in substantial or in a minor form and gives you time to take another measure and make the patient stable. So uterine artery is close to this lower uterine segment incision and it is passing on the side of the cervix. You identify the uterine artery with the pulsation, that it is pulsating. Then you take the suture material, that is chromic catgut number 2, and you will go around 2 centimeter medial to the uterine artery. You will come posteriorly and the assistant give you a good like a visualization, and then you will look for a avascular surface, avascular area in the broad ligament, and you will come to the avascular area to the broad ligament and you come out anteriorly. With a simple measure, you will put the suture material, you will push it and you will give the implant knot. Ask your assistant to step on the knot, step on the knot to make sure that it is a good suture, good knot, and you will take 3 knots, 1, 2, and 3. This is a simple method. You can take another suture around 2 centimeter below, and you can do either on one side depending upon the bleeding and depending upon the hemodynamic stability. You can take one suture this area and one suture around 1 centimeter below. Again, you will go from anterior to posterior. You will come out. You will look for a avascular area in the broad ligament. You will come through it and you will put a knot. This selective uterine artery devascularization is one of the very simple procedures, always to be done again with either chromic catgut number 1, 2, or even 10, and it helps you in everything, it might stop bleeding, it may give you time for the additional measure, and it reduces the amount of bleeding. The another, you can do on one side, you can do on other side. A second knee respiration, which is very simple, is the ovarian artery respiration, because we will do it on another model, because ovarian artery gets supplied directly from the aorta. And once you have done the selective uterine derespiration, then if you think that it is necessary, then you can do the derespiration of the ovarian artery also. Principle is the same. It is the uterine artery which is running into the mesoceltics. You will go from posterior to anterior. You will come out into the avascular area into the mesoceltics, and you will come out and create a window in mesoceltics, and you will put the suture material around ovarian artery. And always be careful that you come through the avascular area and mesoceltics, because sometimes if you are not careful, that it can cause its own issue. So this is about selective uterine artery and selective ovarian artery derespiration, which is a simple technique, does not require much time, and it is effective in minimizing the hemorrhage, treating the hemorrhage, and gives you time for the further measurement. More the time between delivery of baby and placenta, the more is chance of postpartum hemorrhage and shock. So always look for the placenta. And the second thing is trauma, which is the cause of postpartum hemorrhage in around 20% of patients. And always remember that the atony and trauma can coexist. So after you have ensured that the uterus is very much palpable, it is contracted, it is firm and rounded, but the patient is bleeding. So it is time to explore the reproductive tract and the genital tract. Always do it in the operation theater-like facilities, good light, good anesthesia, good equipment available, and all your assistants. When we want to explore the genital tract, we must have this tray ready with us. So this, you must have 2 or 3 speculum of different size, because the tear may be in the higher into the fornix on the very corner, and you might need a different size of speculum as well as the anterior vaginal retractor. In this way, when you are starting exploration, you must have at least 4 straight sponge holding forceps, and I will always suggest that keep this sort of curved sponge holding forceps, which is very, very useful in difficult cervical tear, because it actually negotiates the angle of the cervix. So different size of speculum, vaginal retractor, 4 sponge holding forceps straight, and 1 or 2 preferably curved, and you must have the needle holder. You can have simple needle holder or needle holder with scissor, and always keep 2 or 3 artery forceps ready, because you have to have the, like at the end of catgut, you need artery forceps, and sometimes you have to give the traction suture. So this is the way our sister should get ready with the exploration. Patient is under OT, your anesthetist is with you, and you have good assistance. Now we will pick the speculum. You might need, if it is on this side, you might need 1 more speculum and the vaginal retractor. And then you will see that where is the cervix. Then you catch hold the cervix. 4, this is 1 slit, this is second lip, and you go into the circumferential fashion so that you identify that where is the tear. When you identify that it is a tear either 3 o'clock or the 6 o'clock, then you will stop it, and then you will do the suturing, and first of all you will find the apex of the cervix. So always for the many sometimes at few places we don't have give me the catgut. catgut. So many cases sometimes the catgut is not available. But I want to have one precaution that for postpartum hemorrhage, be it vaginal procedure or be it a abdominal procedure, catgut is the stitch suture material of the choice because the needle is good and it does not get that blood and the injury, and you have got a good knot as well, which is not that good in the acrylic or the other material, other synthetic material. And this is thing, and you must have one or two side needle holder also, and what we use with the needle holder with the silver, and that really helps. And you will put, if you are finding difficulty in apex of the cervical tear, put one suture. First of all, push a pressure from the abdomen so that you can see the cervix. Secondly, you start one suture from the midway or a little lower to the apex, and then put a little traction, and by stitch suture you can reach up to the apex. Always give first suture around 1 centimeter above the apex. You can give interrupted suture and always see that all the tear, there can be bilateral tear, there can be one-sided tear, and before you close the cervix, always see there is no other additional vaginal or parauterine tear. So always start from the above and then go below, and always look for the any episiotomy sputter, any vaginal sputter, any parauterine before you put up the patient again and remove your instrument. Of EPH, and this is about the compression sutures. First of all, when to consider compression suture? When you squeeze the uterus, then the bleeding is stopped and uterus gets contracted. Then the compression suture will be effective. If you compress the uterus and the bleeding is not responding, then compression suture might not be that good choice. So first we will come to the classical B-Lynch suture, and in this we have got, this is a model, it is showing, this is the ovarian ligament, this is fallopian tube, and this is ovary, and here is the uterine artery which is running on. So it is B-Lynch suture is given when there is a cesarean section, and already we have got the lower segment incision. So what are the 4 points about B-Lynch suture? One is the 3 centimeter below the incision line and 3 centimeter from the uterine border. Then the second point is 3 centimeter above the incision line and 3 to 4 centimeter for the uterine border. Another point on the same side, it is the same 3 centimeter from the uterine border and 3 centimeter below the incision line. So 1, 2, 3, 4. And 5, 6, which is from the just opposite to first and second point. So first of all, your assistant compress and you see that it is effective. Then you start doing B-Lynch suture. So there is, just hold me, assistant need is too much, and it is from first point, that is 3 centimeter, you go in. Always put artery pocket, which otherwise you will get lost always. So in, then you go out from the second point. Then the assistant will do this around, it is 3 centimeter from the fundus and compress it. And then we will again go to the posterior surface and we will enter the uterus again, just opposite to point 1, where we have entered. Then, so in, out, in, then again, just opposite posteriorly from the point B, we will again out, then again we will go posteriorly, go to the fundus of the uterus, and then we will again compress it. Then we will go again in and then again out from the anterior surface. So you see when we just pull it, how beautifully it is getting already contracted, and the assistant compress the uterus so that the stitch does not get slipped, and then you will put the knot one, or you can, even if you are comfortable with it, that I am doing the surgical knot 1, 2, and 3, and then you will cut it. Give me a scissor. Yes. So you have cut it and you see that it is done. So uterus is contracted, compressed, and it looks like this is the anterior posterior surface and this is the anterior surface. The posterior and interior situation, and that is effective. You can give a localized use 3 centimeters. You will take the first point as in the B-Lynch suture, that is 3 centimeters for the proposed uterus. It is put again 1 suture from the anterior to posterior. Then again posterior to anterior. And it makes a box, and it helps in some situation, in some select situation. So this is and you see sometimes it is a model, but when it is a uterus and it is sometimes a big size, it needs some practice, and that's why we here and we hope that all society do these sort of program on hands-on as well, and train everybody on this surgical skill. So it is posterior to anterior, then again anterior to posterior. And then again posterior to anterior. So this is a closed suture which helps many times for the localized anatomy. Beside this, रोज कर रहे किसने डिलीवरी कराई थी कितना लेती है हम रिव्यू कर करेंगे ओ माय गॉड चलो जल्दी से डिटेल बॉक्स में कर दूंगे जल्दी कंप्लीट ठीक गुड जल्दी से पीपीआई बॉक्स लेके आओ यूट्यूब के साथ चलो देखो यूट्यूब कैसा कॉन्ट्रैक्टेड है ओ माय गॉड यूट्यूब एकदम रिलैक्स है देखो तुम यूट्यूब को पकड़ के अच्छी तरह से इसको मसाज करो डॉक्टर मनीला ऑक्सीजन दीजिए और दोनों तरफ इंट्राकेट लगाइए और सेंट्रिक पीपीआई बॉक्स लाइए एक तरफ कोएगुलेशन प्रोफाइल हीमोग्राम हीमोग्लोबिन के लिए भेजिए और एक ब्लड क्रॉस नेट के लिए भेजिए पॉलिसिस में ऑक्सीजन डालिए 20 यूनिट दोनों से टेक्निकल इलेक्ट्रिक को एक नॉर्मल चलाएं और बहुत तेजी से दौड़ाएं ऑक्सीजन दीजिए देखो कितना पीपीआई हो 110 पल्स हुआ है इसको मसाज करो और पीपीआई स्ट्रेट आउट ठीक है डॉक्टर इसको फोन करो जल्दी से पीपीआई बॉक्स लाइए ड्रग दीजिए और कैटेटर करो एक जना कैटेटर करिए मसाज करिए 20 मिनट ऑक्सीजन से कर दिया ब्रेक ऑक्सीजन से और दीजिए अरे ऑक्सीजन ने आपने पहले लगाया दीजिए पहले हमें प्रोसोडेन लगाइए और एक लगाइए पॉलिस कैटेटर करिए डॉक्टर बनेगा कि हम लोग सब चीजें कर रहे हैं और कोई रिश्तेदार ना जाए। डॉक्टर में कुछ कॉन्फेक्शन आया है क्या? ठीक। अभी अगर अभी जब तक ये ब्लड प्रेशर बहुत ज्यादा कम हो, पेशेंट का पल्स रेट कुछ नहीं हो रहा है, 60-40 बीपी हो, तो ये एओर्टिक कॉम्प्रेशन आपकी कुछ समय के लिए मदद कर सकता है। तो आप यूट्रस को एक साइड करेंगे, लोटा को फील करेंगे, स्टूल के ऊपर रहेंगे और पूरा स्ट्रेट हेड लेके पूरा प्रेशर देके एओर्टा को कॉम्प्रेस करेंगे। ये दो मेजर है बायोमेजर यूट्राइन कॉम्प्रेशन और एओर्टिक कॉम्प्रेशन, आपको पता होगा। पेशेंट को अटेंड है ना, ये नंबर तो क्या पेशेंट बोल रहे हैं कि वो बेड में और वो झगड़ा भी करते हैं। अच्छा, झगड़ा करते हैं तो अभी हम उनसे बात कर लेते हैं। यहाँ पहले दिखा रहे थे एंटीनेटल केयर में नहीं करते, तो उनको अच्छी तरह से समझाओ कि हमने सब दवाइयाँ दी है और ट्रीट दिया है, लेकिन पेशेंट को कभी भी ब्लीडिंग हो सकती है और उसके कारण आपको 1-2 ब्लड हमेशा क्रॉस मैच करके रखना चाहिए और जरूरत पड़ सकती है और एक बार उनका रिटेन हैंड में उनका कर सकती है।
Thank you, ma'am.
It is done from my side, and a few things a little bit by manual compression it was think, but I think time is okay, and with all August audience we have done with my part also. So
thank you, ma'am, for such a brilliant presentation and videos. We are left with only 20-22 minutes. So first we will discuss internal iliac artery ligation, which is the last step of stepwise revascularization. And then we will have a video on obstetric hysterectomy because the technique is different. Please open IIAL. And okay, if you allow me more 5 minutes, then I will show you how to put a Bakri balloon in LSCS. Yeah, you can start this. Okay, I will just show you the Bakri, how the Bakri balloon is put in LSCS.
Okay, ma'am.
Please start this.
It is very important to put a balloon in a cesarean section.
Yeah, this is very important, ma'am. Now I am showing you how to insert the Bakri balloon if we are doing a cesarean section. So this is the balloon. This is inflation channel, this is outflow channel, and this is a model of the uterus, which I have made myself. Now, this is representing the cesarean wound. Now I will show you how to insert this Bakri balloon in this. First, we will insert this part of the balloon in the cavity of the uterus, like this. And then we will just separate this stopcock and we'll keep it and we will fold it like this. Then we will insert the balloon from here. And there is an assistant on the foot and side who will take this out. I made this model with a water bag, hot water bag.
Wonderful. But sometimes the cervix is very, very hard, specifically in an elective cesarean section, Shashi. Is it possible to push it in that cervix, which is absolutely closed?
Make any prick in the balloon. Ma'am, please repeat your question. So it is very easy to.
Please pause the video. Please pause the video. Elective cesarean, it is very, very close cervix. Then how you push it this?
Ma'am, it is very easy. This Bakri balloon is made of silicone and it is very soft. We align our finger at the internal os of the cervix from the cavity, and then we just push it and the assistant can pull it from below.
Okay.
It is not difficult.
Carry on, please carry on.
Put it from below.
Please carry on.
Can we put it from below and pull it up from the wound, from the incision?
No, then it will cause infection.
Please see the video again, Dr. Jyoti.
No, that is a model of the uterus. If ma'am is asking, we cannot put it.
Please pause the video. I am not able to hear. Please pause the video. Yes, Dr. Jyoti.
I am saying that Dr. Ragini was saying sometimes we cannot push it because the cervix is very closed and it is one finger very tight. So can we put it?
Yeah, it can be pushed because it is very soft and it can be compressed and it is pushed with fingers. There is no problem. At least, and we can dilate the cervix always up to 1 to 2 fingers. There is no problem. Okay. It can be easily pushed. Yeah.
Okay.
So please starting the cesarean wound. Now I will show you.
Start that internal.
First, this is complete. Okay, start the internal iliac vein. Like this. Next, IIAL. So as ma'am has said, I always feel that every obstetrician should know this. So just enjoy the video. So here you see that I've taken you to the classes of our anatomy. In first year, this is abdominal aorta, the greatest vessel of our body, dividing into two common iliac, and then the external iliac and internal iliac. And internal iliac has got these two divisions. And you see that the uterine artery is a branch of anterior division of internal iliac artery. And how does it work? Bilateral internal iliac artery results in 85% reduction in pulse pressure and 50% reduction of blood flow.
So today we will discuss internal iliac artery ligation. First, I will show you how to make a double thread.
We require a double thread.
See in the picture, I am using number 1 silk. I have doubled the thread. Now I am showing you how to do internal iliac artery ligation. In this case, we had already performed the obstetric hysterectomy, and now we are proceeding towards performing internal iliac artery ligation. You see here I am recognizing the structure, the ovary and the infundibulopelvic ligament. And for opening the retroperitoneum, first we will locate the cut end of the round ligament. You see, I have located the cut end of the round ligament.
I am going through the cut end of round ligament.
And from the cut end of the round ligament, I'll go parallel and by the side of the infundibulopelvic ligament up to the lateral pelvic wall, and slowly lifting the peritoneum and taking care not to cause any injury on other structure. And I'm moving towards lateral pelvic wall, and my incision is just parallel to the infundibulopelvic ligament.
That means we are going from round ligament, cut end of round ligament.
I'm opening the retroperitoneum around 5 centimeter, and the retroperitoneum is open now. I'm extending it, not injuring any other structure.
It is basically a loose areolar tissue, so we keep away all the instruments and enlarge it.
This is how it has been opened, and now we'll kept away all the instruments, and with my 2 fingers I'm opening and enlarging the loose areolar tissue. I'm enlarging the incision site. It is a loose areolar tissue, so does not bleed much, and this is how retroperitoneum is opened. Now I will try to locate the important vascular structures. I can see the ureter in the medial flap. This is the ureter in the medial flap, and
I think you can appreciate ureter.
We will work on the lateral side.
There's no fear.
So ureter doesn't come in way once we retract it medially. Now the first and foremost thing for performing internal iliac artery ligation is to recognize the inverted Y. The common iliac artery divides into external and internal iliac artery. You see here, and it takes the shape of inverted Y. This is the internal iliac artery ligation of right side. And you can see here, the external iliac artery is visible. When I press the external iliac artery, and simultaneously when I press the femoral pulse, then femoral pulse goes, and when I lift the pressure on external iliac artery, then the femoral pulse comes. Femoral artery is a direct continuation of the external iliac artery, and this is how we recognize and exclude the external iliac artery, and we concentrate on the internal iliac artery. When we press the internal iliac artery, there is no change in the pulsation of the femoral artery. You see here the external iliac artery is behind my fingers, and the site of our ligature will be around 3 centimeter below the bifurcation, and we will remove the sheath on the artery only at that area where we are supposed to apply the ligature. Now this is a right angle forceps whose end is blunt, and now you see how I am separating the sheath around the internal iliac artery. Just see, look at the movement. It is parallel to the artery. It can never be perpendicular to the artery, because if we do the dissection perpendicularly, then we will end up injuring the other important vascular structures like external iliac vein or internal iliac vein. So this should always be parallel to the artery. You just see, look at the dissection. Very gently, I'm doing the dissection. I'm separating the sheet with the right angle forceps. Its end is blunt, and it is also called mixture forceps. You just see how I'm separating the sheath. Yes, and the proposed site of my ligation is around 3 centimeter below the bifurcation of the common iliac artery. The bifurcation is represented by the inverted V, inverted Y. Now the sheath is being separated. Now doing little bit of more dissection, and I will pass the right angle forceps from lateral to medial. Lateral to medial is the word. Just see, from lateral to medial I will pass it. So I am passing it and grazing through the artery so that not to injure any other structure below. So the right angle forceps has been passed from lateral to medial below the internal iliac artery. Now my assistant is giving me the double thread. I pulled it up. Yes, and now I will cut it at the end, which was double. Yes, here I am cutting it. So the purpose of now the two threads are made, and now I will try to separate the threads as they are entangled. So I will separate the threads, and I am gently, very gently, with utmost care, I am separating the two silk threads. To be very gentle here. Now they have been nicely separated. Now one by one I will ligate them. You see beautifully they have been nicely separated. Now I will ligate the lower one first. My first knot is always a surgical knot, double turns, and look carefully. My fingers are going below in the depth of the abdomen. I am not pulling the artery at all. Just pause, because that will make a catastrophe. So I place the knot just on the top of the artery. I want to say that the internal iliac artery is a very deep structure, and if you pull on the artery after passing the thread, then it will just get torn and blood will go to the ceiling and patient will die. So usually ये कहते हैं अपना सिर artery के सामने झुका दो. I go my head over the artery and I apply a knot gently over the superior surface of the internal iliac artery. Please start the video again. Very gently, not pulling the artery at all. And now my first knot is completed. I am giving the second knot. And now the third knot. Every time I am taking care not to pull the artery, rather taking my hands up to the artery. Now I will cut this. So the first ligature given. Now I am getting hold of the second. We applied two ligature suture, and this should be 0.5 mm away from the first one. So again I am giving a surgical knot, placing it on the top of the artery, and of course 0.5 centimeter away from the previous one. See, there is a distance of 0.5 centimeter between the two ligatures. Just see, appreciate the difference of 0.5 centimeter. Suture, not pulling the artery at all. Now I am applying the second suture. And now the third knot. Second knot and third knot. And very gently, without pulling the artery, I'll cut the thread. So both the ligatures have been applied. Now you see. So you see now this is the inverted Y. And we can see that this is common iliac, this is external iliac, and this is internal iliac anterior division with ligatures.
So the tips for ligating internal iliac artery are open retroperitoneum from round ligament to infundibulopelvic ligament, or 2 cm below and 2 cm lateral to sacral promontory. Then only do finger dissection, and always do bilateral, and always insert the mixture forceps from lateral to medial. If you know internal iliac artery ligation, you can save many lives. My next video on obstetric hysterectomy. Next video. 12 minutes. Yeah. So this is also sometimes required in managing the patient of PPH, last resort. So this was the case, gravida 5, para 4, L4, had vaginal delivery 10 days back. Patient's pulse was 118 and she reported severe bleeding on day 10. Her provisional diagnosis was secondary PPS due to infection, DNA attempted, and patient failed to respond to all the medical and conservative surgical management. So I had to do hysterectomy. It is the same case in which I have done internal iliac artery ligation. So just look at this. This is a postpartum uterus, 10-day, and my first clamp is being applied on the round ligament. And you just appreciate the round ligament. This is just like a abdominal hysterectomy, and usually in abdominal hysterectomy, we just cut the uterovesical peritoneum and push the bladder, but it's my advice that everybody should know how to open the retroperitoneum in gynae case, so that they become perfect in obstetric case to open the retroperitoneum. Now you see I've cut the round ligament and taking ligature on the round ligament, and it is to be reinforced. See, as we say that there are difficulties in doing obstetric hysterectomy because the tissue is very big and edematous. So I will ligate all the structures doubly. So this is what I'm doing here, ligating the structures. And the first knot is always, there should be 2 turns in the first knot, and we should apply the second and third knot each in reverse direction. Now, since this is a young patient, so we will save the ovary. So with Victor's technique, we have inserted the artery forceps, long artery forceps, and my next clamp will be on the ovarian ligament. Can you appreciate the size of the uterus? It is very big size uterus. The planes are very easy in an obstetric hysterectomy, but then the tissue is very edematous and the vessels are very tortuous. So this is the ovarian ligament clamp at the cornu. And it is a big clamp, so you have to take it very carefully and doubly ligate. After this, we will do the same, we will apply the same clamps on the other side, which has been done. And next important step is opening the uterovesical peritoneum. Just fast forward it a little bit by 30 seconds, yeah. You just see how I'm ligating the ovarian ligament.
utmost care is to be taken because it is very, very edematous. And slowly we release the clamp. It cannot be in one jerk. Now the uterovesical peritoneum is being cut. This uterus is full of clots. She did not respond to any medical and surgical management, and her pulse was gradually increasing and BP was going down, and ultimately she was put on ionotropes. So we had to take a decision of doing obstetric hysterectomy. Now you see how I separate I'm getting hold of the uterovesical peritoneum and how I separate the uterovesical peritoneum from the uterus. And the obstetric hysterectomies are of two types, which can be done in postpartum hemorrhage. One is total obstetric hysterectomy, another is subtotal obstetric hysterectomy. In grave emergencies where atonic PPH is the cause, this is a uterine clamp, which I am applying. In grave emergencies, when uterus is atonic, then we do subtotal hysterectomy. But if there is a placenta previa or placenta percreta, or there is any wound extension which has extended up to the colpos, then we have to do a total hysterectomy. In this case, I am showing you a subtotal hysterectomy, which is very fast and it is really life-saving. When the question of life and death comes, then we do not bother about whether this remaining cervix will develop a cancer or not. There is also a technique of vaginal vault suturing in an obstetric hysterectomy that I will show you. First, you see how it is cut. You can make a nick in the lumen and you can see and you can cut. Just I made a nick in the cavity and I'm palpating the cervix, which is below. And I will just cut through the cavity. Even when you do a total hysterectomy, just palpate the cervix, make a nick on the anterior wall of the vagina, and gradually you can move from inside out. That's a very easy method of completing the hysterectomy. Now you just can appreciate, as soon as I open the lumen, you can see a blood clot. Just imagine on day 10 how many blood clots she had. And because of these reasons, it was not responding to any medical and surgical management. So this is the case of subtotal hysterectomy. You can appreciate that the uterus is very pale and flabby also. She had an atonic PPH with lots of clot inside. Now I got hold of the remaining part with Alice tissue forceps. You can use remanipatase also. Now look at the technique of the suture. That is very important. It is figure of 8 sutures which we should take, because with single suture, there will not be any hemostasis. And if we take continuous suture, then it will be loose. Again, there will not be any hemostasis and cut through too. So it is advisable that we should take figure of 8 suture. In fact, in gynae cases also, on the vaginal vault, I always apply figure of 8 sutures. So please try to see these figure of 8 sutures. This is the picture of figure of 8 sutures, which I apply on the remaining part, whether it is a vault or cervix. I use number 1 Vicryl for the whole procedure. If there is a significant cut through, which is another problem in obstetric hysterectomy. So you know that in surgical knot, we apply 2 turns on the first knot. And when there is cut through with number 1 Vicryl, then sometimes I use number 10 Vicryl. And as Dr. Sadhna ma'am has said, catgut is a very good suture material in obstetrics. Yes, I do agree. Where Vicryl is not working, not giving output, you use catgut. There is no harm. Because after all, these surgeries are only life-saving surgeries. So this will be another figure of 8. So I just want to request everybody that remove the fear of managing PPH. You can do everything. You can do an obstetric hysterectomy also. And with little trial and practice, you can do internal iliac artery ligation also. You know, even today, sometimes you do not get good surgeons in emergencies. So please try to learn yourself. Our basic purpose, see you here, see the cut section. So many clots this uterus had. And as SP was postpartum uterus, this patient received so much of blood. And this patient was discharged in stable condition from my hospital. I did an internal iliac artery ligation also on her. Thank you so much. Now, if time permits, then I will show. Oh, it is over. So you are open to questions.
Question, only 2 questions in the chat box. No one asked if there's any question.
Yeah, there was one question why the sheath was separated. I tell you one thing, that this internal iliac artery, internal iliac vein, these major vasculature are entangled in one sheath only. So if you do not separate the sheath and try to ligate the internal iliac artery, then you will definitely puncture the internal iliac vein, and that's a catastrophe. So we have to always gently separate the sheath. And we have to make space for internal iliac artery. And when I'm passing my mixture forceps from lateral to medial, I'm just grazing through the posterior surface of the internal iliac artery so as to not injure the internal iliac vein.
Thank you, Shashi. And one thing I will comment here for everyone, along with this, if you see the last slide of the Shashi, that is very, very important thing, that always learn massive blood transfusion protocol. Only PRBC is not going to help you. If you are infusing 4 PRBC, suddenly you have to infuse 1:1:1 your platelets and the plasma. And with this, we come to end an excellent presentation. We will come again with a full PPH only, Shashi, for you and Sadhna. And interactive session. We will go forward. Over to you, Jyoti and Promila, to take over the next 2 sessions. Dr. Mala and Dr. Anita is there. Welcome. Carry on the next session, Jyoti and Promila.
Good evening, everyone. We come to the next session, that is Eclampsia drill. For that, I'd like to invite Professor Mala Srivastav. She is senior consultant and professor and consultant in Sir Gangaram Hospital. She was past president AOGD 2020-21, and she is vice president elect ISOPAP 23-24. And she has a lot of awards and honors to her credit. Welcome, Dr. Mala. And the next speaker is I welcome Dr. Anita Rajoria. She is presently senior consultant and HOD Department of Obs and Gynae, Sardar Vallabhbhai Patel Hospital, Government of NICT of Delhi. Presently, she is Asia Oceania Federation of Obstetrician and Gynecology, and she has a lot of major achievements and honors and awards to her credit. I welcome you, Dr. Anita Rajoria. both of you for eclampsia drill.
Thank you, Dr. Promila. Thank you for inviting us for this prestigious workshop. Safe motherhood is a dream of all, and we are, committed to this. So we have made videos for eclampsia. Mala will be sharing the eclampsia drill. We are not going into the theoretical part of eclampsia management. We will just show you one small skit which will narrate how we manage these patients when we receive them in our casualty department or gynae emergencies. So first video, Dr. Mala is going to share. Dr. Mala, please.
Eclampsia is it? इसको पिछले 1 घंटे से दौरे आ रहे हैं.
कोई नहीं, घबराइए नहीं. पेशेंट को दौरे कब आए हैं?
पिछले 1 घंटे से आ रहे हैं.
कितनी बार आए हैं?
2 बार आए हैं.
गिरी तो नहीं थी पेशेंट?
गिरी नहीं थी, बैठी हुई थी, बोली अजीब सा लग रहा है और सर में दर्द हो रहा है.
किसी डॉक्टर को दिखा रही थी?
हाँ, पास के एक डॉक्टर को दिखा रहे थे. जब
BP
तक
तो नहीं बढ़ा हुआ था?
जाते थे. बीपी अभी तक तो बढ़ावा नहीं आया था.
सिर में दर्द, आंखों में धुंधलापन?
सिर में दर्द रहता था पिछले कुछ दिनों से. आंखों का धुंधलापन जैसी कोई शिकायत नहीं थी.
पैरों में सूजन तो नहीं थी?
पिछले 3 दिनों से पैरों में से सूजन आ रही है. इनफैक्ट चेहरे में भी 2 दिन से सूजन लग रही है.
अच्छा. Dr. Simran, it's an emergency. Please call Dr. Pooja and Shaista sister.
Yes, ma'am.
Yes, Dr. Shweta. Ma'am, she is a primary gravida with 39 weeks of amenorrhea, and she was showing to some local doctor, and she had a history of fits 2 times. One 30 minutes before, and next was 10 minutes before. And she has no history of high blood pressure, but she is complaining of pedal edema since last 2-3 days.
Oh, okay, Dr. Shweta, you check for the airway.
Okay,
Sister Ji, you secure the IV line and
Okay,
prepare IV labetalol 20 mg and loading dose of Maxel.
Okay.
Dr. Simran, please call Dr. Tarun.
Yes, ma'am.
Sister Ji, have you secured the line?
Yes, ma'am.
Please take the sample for the CBC, LFT, KFT, serum uric acid, epigenetic PT, INR, and save some sample for cross-matching.
Okay, ma'am. Ma'am, injection lobet is ready.
Okay, push in.
Okay, ma'am.
Repeat the BP. Repeat BP is 160/100. Dr. Simran, please call Dr. Tarun.
Yes, ma'am.
And Dr. Sister Sadhna, please prepare for the catheterization and I'll do the PV. Repeat BP is still 160/100.
Okay, ma'am.
Sister Ji, please push in Maxel injection loading dose.
I am pushing the 4 gram loading dose of myself.
Okay.
I'll give it.
Repeat PP is 150/90. Dr. Simran, have you called Dr. Tarun?
Yes, ma'am.
Sister Ji, please prepare for the Foley's catheterization and I'll do the PV also.
Okay, ma'am.
Good morning, sir. So she is a primary gravida, 39 weeks with antepartum eclampsia. She has thrown 2 fits 30 minutes and 10 minutes ago. We have given IV labetalol 20 milligrams at repeat BP is 160/110. We have given magnesium sulfate also, and now we are preparing for the catheterization and PV examination to be done.
Okay, and you have given the loading dose?
Yes, sir.
We have given.
What is the loading dose?
4 gram IV MGSA4 I am giving the loading dose.
And how do you dilute that magnesium sulfate?
12 ml go.
You have taken 4 ampulle of
4
magnesium
ampule of
sulfate,
yes, sir.
50% volume by volume,
Yes, sir.
with a 12 ml of
Normal saline and 8 ml of
and
MGSA.
dissolved to be substituted in 20 ml saline.
Yes,
Sorry.
sir.
And you have given over
20 minutes.
over 15 to 20 minutes
15 to
time.
20 minutes.
Okay. And you have checked the BP?
Yes, sir. Its repeat BP is 160, 100.
And you have given how much Levotalol?
20 milligram IV.
20 milligram IV. Okay. So we have to repeat the BP again after 10 minutes.
Yes, sir.
Okay. And we have to do the internal examination also to see whether the finding of the internal findings, to see
Okay,
if she is in labor or not.
Yes, sir.
So can you please do the internal examination?
Sister, please bring the thread. Yes, sir.
What is the examination finding?
So the patient is doing okay. Her pulse is 92 beats per minute. BP is 140 by 90.
Okay.
Uterus per abdomen, uterus is term size. She's having good contraction, and fetal heartbeat is 140 beats per minute.
Okay.
So on PV examination, she is 4 centimeter dilated, 60 to 70% effaced, and vertex is like -2.
Okay.
ARM has been done and LycoRed is clear. And so on knee jerk, it is brisk.
Brisk. Okay. So you have secured the airway?
Yes.
Huh? You have secured the IV lines?
Yes, sir.
So start the IV fluid. 1 ml per hour per kg should be given, per kg per hour. And her body weight is 65.
Yes,
Huh?
sir.
So you should give 65 ml per hour fluid. Okay, you can start with the Hartmann solution or isolate him. Okay.
Yes, sir.
And
So I'll be repeating the BP every 30 minutes.
yeah, we will be repeating the BP and keeping her findings in mind. That please inform me after in the due time and keep me in loop. We should allow her for the spontaneous labor trial. If any is noted, then we will plan accordingly.
Okay, sir.
And we have to counsel her relatives also regarding her current condition and regarding further management the plan.
Okay, sir.
कि मैं डॉक्टर तरुण हूँ, मैं आपके पेशेंट को एग्जामिन किया है, आपका पेशेंट को इनिशियल मैनेजमेंट मैंने दिया है और हम लोग का टीम ने दिया है. अभी पेशेंट का कंडीशन आपको पता है?
नहीं सर, पेशेंट ठीक तो है ना?
पेशेंट ठीक है, अभी तो उनको सीजर अटैक आया था, है ना, दौरे पर थे, अभी कंट्रोल हो गया है. हम लोगों ने इनका बीपी चेक किया तो बीपी काफी हाई थे, तो बीपी के लिए दवा भी दिया हुआ है और इनका जो सीजर आए थे उनको कंट्रोल करने के लिए मेडिसिन दिया हुआ है. और अभी बच्चे का धड़कन वगैरह भी हम लोगों ने सुन लिया है, बच्चे का धड़कन सही चल रहा है, अभी के लिए सही चल रहा है. और एग्जामिनेशन फाइंडिंग में नीचे का रास्ता खुला हुआ है, तो हम लोग इनको नॉर्मल डिलीवरी के लिए कोशिश करेंगे. जैसा सारा सब कुछ
सर, आपको जैसा अच्छा लगे,
जैसा सारा सब कुछ ठीक रहता है हम लोग आपको बताते जाएंगे. और अभी इनका बीपी हम लोग दोबारा देखेंगे, दोबारा नापेंगे, तो उसमें अगर हाई रहता है, क्या रहता है, आपसे बात करेंगे. अगर सारा सब कुछ नॉर्मल रहता है तो नॉर्मल डिलीवरी के लिए हम लोग ट्रायल देंगे. ठीक है, आपको और कुछ पूछना है?
नहीं सर, ठीक है, बस
हम लोग आपको फर्दर बताएंगे. हाँ, हम लोग आपको फर्दर बताएंगे कि बच्चे का धड़कन भी कैसा चल रहा है, बिकॉज इनको अभी हम लोग कंटिन्यूस मॉनिटरिंग पे डालेंगे बच्चे का धड़कन को. तो बच्चे का धड़कन कंटिन्यूस मॉनिटरिंग पे चलता रहेगा और एग्जामिनेशन फाइंडिंग आपको फिर हम लोग कुछ देर के बाद आपसे बात करेंगे. डॉक्टर सिमरन प्लीज कम.
Yes, sir.
Dr. Simran, you have documented the case.
Yes, sir.
You have done all the documentation part.
Yes, sir. All the documentation is done.
Okay. And her BP, everything.
Yes, sir. Everything is
documented.
Huh? Yes, sir. Everything is noted.
Huh? Okay, fine. Sister Saista, please come.
हाँ जी. Yes, sir.
हम लोगों ने अभी इनका ना नॉर्मल डिलीवरी के लिए ट्रायल देंगे. So keep the delivery suit ready. PPH kit it has to be ready.
Okay, sir.
And इनका रेगुलर इंटरवल पे BP, पल्स, रेस्पिरेटरी रेट, नीजर, ये सारा चेक करते रहना है आपको. ठीक है. एंड कुछ भी ऊपर नीचे लगे, यूरिन आउटपुट आल्सो, कुछ भी ऊपर नीचे लगे तो हम लोगों को बताना है. ठीक है.
This video has been done by our students, and you see one we have to understand eclampsia is a very important obstetric emergency, which if managed promptly can be definitely saving lives. Will be able to save many lives if the eclampsia is managed properly. All obstetric units should have up-to-date protocols in place and should conduct mandatory drills to prepare nursing staff, obstetric providers, anesthesia staff working in these units to manage eclampsia. Any pregnant women presenting with convulsions in later half of pregnancy should be treated as eclampsia until proved otherwise. Our first diagnosis always is eclampsia. Everybody should not run towards the patient. We should decide who is the team leader, and the team leader should decide about the airway, oxygen supplementation, catheterization, cannula, IV cannula, how to put, and at least 2 cannulas should be put. And through it, we have to take the blood samples for CBC, LFT, KFT, uric acid, coagulation profile, and some sample has to be saved for blood cross matching. Without waiting for these results, we should give Maxulf because that is an anti-eclamptic or anticonvulsants. What are the principles of management? Avoid injury, give padded bed rails, maintain oxygenation, minimize aspiration by lateral decubitus position. Now we see this patient was given lateral decubitus position, but later on she was kept in the supine position because we had done the airway, we had done the suction, and she was under supervision of the doctors. So ideally she should have been in the left lateral position, but since we have done the airway, we have done the suction, so we could have managed her in the supine position as well. Control of blood pressure is important, and a plan for delivery has also to be important. We should know where every labor room should have eclampsia initial management toolkit. This we will show in a video again later on. So the idea is to stabilize the patient, maintain IV line, maintain oxygen, maintain patent airway, oxygen inhalation by face mask, and Foley's catheterization. We have to assess the patient for injuries. The patient just threw a fit and had a fall. Vitals, ABG, GCS, look for pulmonary edema, DIC, abruption, or any other causes of seizures. So this is the algorithm. Patient has to be admitted, maternal fetal evaluation, IV Maxulf, steroids for lung maturity if possible. Antihypertensive is blood pressure 160 by 110. If there is eclampsia, pulmonary edema, ARF, DIC, pregnancy is less than 22 weeks, abruption, immediately delivery without waiting for the steroids. If there is help, maybe severe fetal restriction, both restriction, oligohydramnios, Doppler with reverse diastolic plate, and period of gestation is 33 to 34 weeks. Maybe we can wait for steroid cover if the conditions allow us. But if the period of gestation is less than 24 weeks, we have to counsel and then terminate the pregnancy. Between 24 to 32 weeks, we have to see how our NICU is functioning. If our NICU is not capable of saving the fetuses below 28 weeks, then we should not promise the patients like that. But if we think of NICU can save the patient, we give antihypertensive, daily monitoring of fetal evaluation, if possible, deliver at 32 weeks. What are the components of medical management? You have seen Maxulf, antihypertensive, anti-epileptics, if there is recurrent seizures only. Otherwise, we are able to manage the eclampsia with Maxulf and antihypertensives if required. And of course, we have to monitor with lab investigations. Two kinds of regime are there for Maxulf, and this each and every student should know. Each and every staff in the labor room should know how to prepare, how to give the Maxulf loading dose. So we get 1 ampule of Maxulf, which has 2 ml, 1 ml contains, it's a 50% of 4 gram diluted in 20% to be given slowly IV over 15 to 20 minutes. You take 4 ampules, that means 8 ml, you add 12 ml of distilled water, make it 20 ml, and you infuse it over 15 to 20 minutes slowly. And 5 gram IM, 50% is given in each buttock, that is total 10 grams IM. 4 grams IV, 10 grams IM. If this loading dose does not control the fits, then after 30 minutes, you can give repeat 2 gram 20% slowly IV over 5 minutes. And maintenance dose, 5 gram IM alternate buttocks after monitoring every 4 hours. This is very important. Other is Zuspan regime, loading dose of 4 gram over 5 to 10 minutes, followed by maintenance dose of 1 gram per hour infusion. Monitoring by presence of patellar jerks or knee jerk, respiratory rate more than 16 per minute, urine output more than 30 ml per hour in last 4 hours. You have to continue the Maxulf till 24 hours after last delivery or after, 24 hours after delivery or 24 hours after last fit, whichever is later. Maintenance dose in patients with renal insufficiency. If the knee jerk is absent or urine output is less than 30 ml, you have to withhold the Maxal. If respiratory rate is less than 16 per minute, withhold Maxal. And you have to give the antidote calcium gluconate 1 gram IV 10 ml of 10% solution. This is labetalol algorithm. We prefer labetalol as a first line of antihypertensive. But we have to avoid parenteral labetalol with active asthma, heart disease, congestive cardiac failure, and we have to use it with caution with history of asthma. So labetalol, how do we give? 20 milligram IV over 2 minutes. Repeat BP in 10 minutes. If systolic blood pressure more than 160 or diastolic more than 110, administer labetalol 40 milligram IV over 2 minutes. If BP below threshold, continue to monitor. If BP is still not controlled, then we have to give, if systolic blood pressure more than 160, diastolic 100 more than 110, administer labetalol 80 milligram IV over 2 minutes. Again, if the BP does not fall below systolic 160 and diastolic more than 110 is there, then we have to repeat BP in 20 minutes. Now, if by 3 times, if we have seen that the labetalol is not able to control, then we have to add another antihypertensive medicine like hydralazine, and which has to be recommended by specialist. If now, once the BP is controlled, you have to monitor the BP every 10 minutes for 1 hour, 15 minutes for 1 hour, 30 minutes for another 1 hour, then every hour for 4 hours. You have to see if the labetalol is been given and the pulse rate becomes 60, then we have to hold IV labetalol. Maximum cumulative IV administered dose of labetalol should not exceed 300 milligram in 24 hours. So this chart shows the antihypertensive medication. We spoke in detail about the labetalol. Hydralazine, if we are giving 5 milligram IV or IM, then 5 to 10 milligram IV every 20 to 40 minutes in a maximum cumulative dose of 20 milligram. Comments, higher or frequent doses is associated with maternal hypotension, headaches, abnormal fetal heart tracings, and may be more common than other agents. Nifedipine, especially if the patient has a history of asthma, then we cannot give labetalol. We have to give nifedipine. 10 to 20 milligram orally, repeat in 20 minutes if needed, then 10 to 20 minutes. Maximum dose has to be 80 milligram. We have to observe for reflex tachycardia and headaches. Sometimes if there is recurrent seizures, we have to give levipremil 1000 milligram loading dose following by 500 milligram 12 hourly. Midazolam, diazepam, lorazepam, phenytoin, these are the other choices. You have to refer to tertiary care center if there is uncontrolled blood pressure, continued fits, oliguria after 48 hours of delivery, coagulation failure, persistent loss of consciousness after 24 hours of convulsions. How to deliver? If conditions are favorable, induction with ARM and oxytocin. We try to cut short the second stage by forceps of vacuum. Unfavorable, ripening with gel or intracervical indwelling catheter. Indications for cesarean, uncontrolled seizures, deteriorating maternal condition, failed induction, fetal distress, or any other obstetric indication. You have seen the eclampsia drill. Now, Dr. Anita, what do you comment about the postpartum management of eclampsia?
So very rightly you showed the drill. Regarding drill, first of all, I will just like to say that there should be one recorder also. One person should be assigned who keeps on recording also what all.
Yeah, Simran was doing that.
Yeah, and another thing which is important is the good point was that briefing and debriefing both were done for patient relative. It is very important to keep the patient's relative informed about the condition of the patient. Then you have already highlighted why she was being treated in supine position, because she was already under direct supervision of doctors. Otherwise, left lateral position and preferably intranasal oxygen should be administered if there is rapid succession of seizures which are following on. Rest all the points were highlighted very nicely by the persons. Another thing is, whenever we are dealing an emergency, we should ensure that whatever instruction the team leader is giving, it is getting across to the team in a very clear manner, so that we are able to avoid medical errors, which may itself be very hazardous for the life of patient. And one good point sister was doing was, she was confirming that I have given maxel. So that is very important, that whatever instructions are given, and then it is it is reiterated by the person who is giving the advice, that the team has understood, and when carried out, the instruction are carried out, loud and aloud. It is told to the whole team that it has been done. Now we all are aware that eclampsia may present antepartum. It may at times present intrapartum also and postpartum also. So many patients, around 30% patients will present with eclampsia in postnatal period. So we are caught unaware because blood pressure was all right. If you are not careful about BP monitoring in postnatal patient, we may encounter this. So keep on recording blood pressure. Be vigilant for 48 to 72 hours, because patient may present with eclampsia. And another thing is, eclampsia may be atypical also. It may be without proteinuria, it may be without hypertension, as Mala has already highlighted. Any convulsive disorder must be taken as eclampsia until ruled out otherwise. So we have to be very vigilant in antepartum, intrapartum, as well as postpartum phase. Then there may be atypical presentation also. There may not be complete tonic-clonic seizures, because there have been studies that they may be having partial seizure also. So be vigilant about any abnormal body movements you see in the patient, especially in intrapartum or postpartum phase. Regarding the chart being shown is so beautiful. You should have the color coding, and everybody should know which color should go in which. Like PPH, Dr. Shashi and Sadhna ma'am have highlighted so well, gray and green should be there in all the labor rooms. Similarly, for this also, you should have all the things 16, 18, and at least 20 gods available, because in the eclampsia patient, we are not very enthusiastic about giving IV fluids. So that is very important. And regarding kit, we will be showing how to assemble the kit, and every labor should have that toolkit in the labor room ready. So we can show the video of
every PG should know what is the color of 14 gauge, 16 gauge, 18 gauge, 20 gauge. They should know. That is the most important thing. Every staff in the labor room should also be acclimatized with these color coding.
And what, when the students are in MBBS, and they are how to remember this, you remember it by layers of earth. Like core of earth is fiery red or orange, then it is the thickest 114, then gray is 6, then gray is 16, then dhara is hara bhara upar, so it is green, then pink flowers, blue sky, yellow sun, and purple is your universe. So you can remember that way, from inner to outer layers of earth. You can very easily remember the color coding of these IV cannula.
Mr. Ankit, please display the second video.
Eclampsia is an obstetric emergency, and whenever a patient of eclampsia comes, it has to be managed by a team. Doctors do their team work nicely, and they do know what they have to do. But there is a very important component of management of eclampsia patient, and that is the eclampsia kit. Today we are going to tell you what is the components of eclampsia kit. Sister, where is the eclampsia kit? Kindly bring it
Yes, ma'am.
Every staff should know where the eclampsia kit is present in the labor room.
See, this is the eclampsia kit, and you can see the components are written here, so that there is no confusion and nothing is left out. So what are the components of eclampsia kit? There is pre-filled lab forms, consent forms, blood forms, and vacutainers. This is the blood form. These are the consent forms. In our hospital, we have HIS system, so we do not have lab forms, but there are vacutainers present. Gloves, bandages, cotton, sticking plaster, gauze, plastic airway, suction catheter,
Nodal airway, yes.
Foley's catheter with Eurobag, syringes with needle, 2 cc, 5 cc, 10 cc, 20 cc, intracath, 18 and 20 gauge, plus 3-way. BP apparatus, injection Maxal, 14 ampules, normal saline 100 ml, 2 bottles, injection labetalol, injection calcium gluconate, injection hydrocortisone, Ryle's tube, adult laryngoscope, tunicate, as well as lignocaine jelly. So eclampsia kit should always be ready, and we should know where the kit has been kept so that it can be easily assessed during an emergency.
And we have to keep on checking that all the things which are there in the list, they are available, and our injections, they have not become, they do not get expired, because these are life-saving drugs. We should be very, very sure. We should keep on, whenever we are taking charge of labor room, at least once in a day, we must check all the labor room trays when we are taking over for the duty. So eclampsia kit is one of them. It should be carefully and sincerely checked every day.
Periodically, the expiry date of the drugs have to be checked, and the date should be put that this date the drugs have been checked and the expiry is still waiting. So that has to be, regular check has to be done, as Dr. Anita already told. So key messages: clinical priorities in severe preeclampsia: control the blood pressure, prevent seizures, restrict fluids. It is just, the fluid is 1 ml per kilogram of body weight in 1 hour. If the patient's weight is 60, you have to give 60 ml per hour. If it is 70, you give 70 ml per hour. And there has to be plan for further management, plan for birth, plan for waitings for steroids. That plan has to be made then and there. And the learning points are, you have to know communication between staff should mention specific BP measurements, specific vitals of the patient, use MEOS, that is modified obstetric early warning sign systems, escalate appropriately. Maxal is given for seizure prevention and treatment and not BP management. Maternal stabilization is always a priority before we are planning delivery or before we are planning anything else for the patient. There are a few points that I would like to say. that everybody should know how to detect the magnesium toxicity and how to treat them. That is important. Magnesium toxicity occurs if there is a loss of deep tendon reflexes, decreased respiratory rate less than 12 per minute, urine output goes below 30 ml per hour, or there is a chest pain, heart block, pulmonary edema, or the saturation is falling below the 95% of saturation is there. And we should also know how to manage magnesium toxicity. We have to stop magnesium therapy. We have to estimate serum magnesium and creatinine levels. Injection of calcium gluconate, 10 ml, 10% solution, IV slowly. Fluid we have to give and give forced diuresis. That is important. Sometimes we have to be prepared for intubation of the patients. That is why adult laryngoscope is always in the kit, and facilities for intubation and the Boyle's trolley should also always be there somewhere in the labor room in case the necessity occurs. We have to take the help of a multidisciplinary team. Our anesthetist is a very important part of this multidisciplinary management of the eclampsia patient who is not responding to therapy of Maxulf, antihypertensive, is going on throwing fits. Then sometimes these patients, they land up into status eclampticus. Then we have to intubate them, give them sedation, and request our anesthetic friends to look after them. So what are the indications of intubation? Patient remains unconscious in the post-seizure period. Seizures are not controlled. They go into patient goes into a phase of status eclampticus. There are signs of aspiration, or there is persistent hypoxia. Then in that case, we have to give midazolam to this patient or fentanyl to this patient and then intubate them. And that is important. Once the patient is having status eclampticus, patient has to be shifted to the ICU and has to be taken care by the multidisciplinary team. Over to you, Dr. Anita.
Thank you, Mala. We should all be aware of status epilepticus also. So what is that? RPGs should know that any fits which remain unabated and they keep on happening one after another in rapid succession without gain of consciousness at around for 5 minutes, then you call it at status. You have done all the efforts to abort the fits, but it still remains unabated. So you definitely will call in your critical care and anesthetist friends. This patient will definitely need intubation. I just want to highlight that we must be ready with eclampsia kit all the time in all labor rooms, and especially in casualty also. We must display the contents of eclampsia kit in our labor room so that everybody is aware. And as we have reiterated again and again, it has to be checked regularly. So just for the revision, I will just say what are the contents. It is, mainly having for airway management, you have Godel's airway, you have bag and mask for ventilation till intubation is done. Then you should have oxygen tubing available in the kit itself. You should have Yanker suction so that patient does not aspirate during the convulsion. Then you should have access for cannulating the patient. You should have all the cannulas 16, 18, 20, tourniquet for same, so that you can put your cannula easily. Fixation tape should also be there so that we are not running here and there at the last moment. The patient should be taken care of in a very cool, in a very shant ambience should be there, so that patient does not unnecessarily get stimulated by any of the visual or auditory sounds. So that is very, very relevant in this. Then IV fluids, as she has already highlighted, have ringer lactate in that. Lomus saline should be there. Then you should have distilled water also in the kit, and IV sets definitely. Regarding drugs, you should have clearly labeled tray, that where is magnesium sulfate lying on the tray, then where is injection labetalol for emergency injection. Hydralazine should also be there if available in your pharmacy. Calcium gluconate, definitely. If you get magnesium toxicity, then you need to have calcium gluconate available with you all the time. Lignocaine should be there, injection lignocaine, nifadivine capsule to bring the blood pressure down if you do not have any other antihypertensive during that period. Then injection diazepam, atropine, adrenaline, and Lasix, like any other emergency tray, you should have there in the kit itself. And you should take, along with that, you should have readily available blood sample collection bottles, as she had shown in her video, spirit swabs. You should have urine albumin sugar strip bottles, because you want to do it bedside. You should have that available in the kit itself. For Foley's catheter, for catheterization, Eurobag, for, it is very important for output monitoring. Reflex hammer should be there. Otherwise, how will you give the second dose without checking for the knee jerk? So surgical gloves should be there inside it only, 5-6 pairs you should have. BP instrument should be there, suction catheter, and checklist for vital monitoring should be there. So consent forms, forms which are, giving the prognosis of patient about maternal and fetal risk, they have to be explained to the patient's relative at regular intervals, so that patient's relatives don't know what is the current status. And if the eclampsia, is not responding to your treatment, you plan for delivery, as Mala has clearly highlighted, because delivery is the treatment ultimately for eclampsia. So that is all I wanted to add. If there are any questions, we can take them, Mala. Or you want to add anything?
Just one thing. Whenever we are having eclampsia drill, we have to also remember that these patients, they can land up with PPH as well, because simultaneously there can be coagulation failure as well. Due to the long standing preeclampsia, there can be coagulation derangement. Their patients may be going into HELP or DIC. So together with that, whenever we are taking the delivery, we should be very sensitive about PPH in these patients as well. And we know PPH can occur in low risk patients, but these patients of eclampsia, they are definitely a risk for PPH. So we have to be prepared for PPH in these patients as well. And in the postpartum period,
you should collect the hematological test we have sent you. We should always collect them in time, so that we can intervene in time, because coagulation profile itself might have been delayed. So you should you should be very, very careful regarding that, because very well highlighted by you, patient may start having PPH any moment because of coagulation failure itself. Dr. Josna has joined. I think I will ask her to comment on this drill, because she is an expert in this critical care field. Dr. Josna, are you there? Will you like to say something?
Yeah, hello, Dr. Anita.
Hello, thank you.
Can you just repeat what question you were asking?
I was asking that if you want to comment on our video, any of the video, if you were able to see our video, eclampsia drill and the kit, eclampsia kit video we had.
I saw the last 15 minutes when I joined just now. So it was, I think all the things which are essential have been included in the kit and have been described very nicely. I was listening to you. You have, I think nothing has been left out. Everything has been very nice. And I heard Dr. Mala's talk also about the antihypertensives. So I think everything has been very well covered.
So thank you, Dr. Josna. If there are any questions, we can take them.
Dr. Sadhna is writing about transcervical clamp of Dr. Paili. Ma'am, you can give your comments.
Actually, there was a question about this cannula and the transcervical clamp. So that's why. So that was the SR. It is our own Indian innovation, and we should be proud of it, because anything can work any day. So what is the principle of SR cannula? That it has got multiple holes, and when you give the suction, then the uterus retract, like it चिपक जाता है जैसे बिल्कुल, and it like evacuates blood clots. So Dr. SR Samartharam, he has given a very like a strong review of his own experience, and it is like available on his website. And what Dr. Pally says, that is a transcervical clamp, and sometime what happened, today we didn't discuss the like a off the road thing actually, but sometimes very very bad cervical tear, when you are really not able to reach anywhere and patient is bleeding, like, so you can clamp uterine artery from vagina, and you can give the transcervical application. Sometimes it helps in you other measure like stitching cervical tear, and especially when you like the patient need transfer, then you can keep that clamp on the wave, like in the vagina same, and you can say, so the patient is relatively hemodynamic stable. And likewise Dr. Pally's aortic clamp, it is like 10 years ago we were really frightened to feel that how we can clamp aorta and what will happen to all vascular supply, but his work on placenta accreta has been recognized, and it is something that it gives you time that you do the hysterectomy or embolization and patient is settled. So it is all our Indian innovation, and we must be proud of it. It is in low resource setting like SR cannula, like condom tamponade or Chhattisgarh tamponade, which has got the drainage channel as well, or be a high resource setting like Dr. Pally's aortic clamp for the placenta accreta. So these are all things, and as if we don't know what we are going to face this day, and that's why we think we must have the SR cannula. I also had a gift from Mr. Samartharam, and she always keep the stall also in all AICOG and everything. And likewise aortic clamp, I have no experience, but Dr. Pally is so confident, and it is a recognized like measure in placenta accreta. So thank you, Promila, for give all questions, so that
we have experience about the aortic clamp.
Yes,
cannula I have used in the SR cannula when we have put in the cannula in the uterus. For how long can we keep it, and how much pressure should we generate?
Actually, Jyoti, that is the issue, because it is so much, uterus is so much retracted, it is difficult to like release it, because the uterus just sucks on it. So he says that he, like what Samartha says, that the wait for a little, let the pressure release on their own, and you remove the cannula just after a few minutes, 5 or 10 minutes. So don't try to push like we do in MTP, we push and we go. So don't push, because it will just stick to uterus. So be patient, wait for it. So when the release pressure is released, then you take out.
Even longer you can keep, 15 to 20 minutes.
I kept it even 30 minutes.
Yes,
30 minutes you can safely keep, and then once the patient is stabilized, and then you slowly release, and the cannula. I have been using this cannula. It's very effective.
I think Sadhna ma'am will agree with me regarding eclampsia. One thing is important, that you know, in while we are training our peripheral workers for that, the support system, the INMs and ASHA workers, they are now being trained to give loading intramuscular dose of magnesium sulfate. So they are not trained to give IV, so at least they can give 5 gram intramuscular in each buttock as loading dose while shifting from primary care to secondary or tertiary care hospital. So that is one thing important.
This is very important consideration. Actually, जो हमारी ground realities है, people are really, even in a simple person nursing home, people are little bit scary about giving full dose of Richard regime, that is full IV. It may be a little less effective, but what ISHP says very rightly, you make your own protocol, but give Maxel. even the 5-10 milligram intramuscular is okay, a loading dose is okay. So don't go on the making thing very, very complicated. Whatever works in our setting, so we must have our own protocol.
Yeah.
Developed country says that they do the Maxer when the patient is having proven severe preeclampsia. And our setting says that whenever the patient is having any feature, we should give prophylactic because we cannot manage many complications. So issue with all the present and future leadership, Ragini and Anita and Mala and Dr. Jyotsna in the peak institution, issue is that we should not, problem क्या होती है, हम लोग उसको reject करते हैं, हम दूसरे का fear है, कुछ नहीं होगा आप करिए, but we have the magnesium sulfate toxicity और कोई single person nursing home किसी problem में नहीं पड़ना चाहता, maybe a little bit here or there. So we should recognize that what is needed at the periphery level, we should make them confident. Yes, what Anita says ना, आप 10 milligram, 10 ग्राम आप मैक्सर दीजिए और पेशेंट को शिफ्ट करिए, note it down. So it is safe, it is effective also, and we have got this Dhaka regime. And why it is all there? Because we are the very low, but the low weight of the patient, and this low dose can also be effective. So believe in our worker, understand their problem, don't like bombard them with the thing, and whatever is that, like in my hospital we will give this, in Gangaram we can give this, in UCMS we can give this, and at the PSC you can give this. But build confidence, like don't take away their confidence and always make them guilty. What is happening? Too much expertise, everybody is throwing up sense of guilt. हमने ये नहीं किया, हमने वो नहीं किया. And that is really, हम लोग ACOG को रटते रहते हैं, but we must understand what is workable for our healthcare provider also, not only for the patient. And as an expert, I always say, all experts are here today. Always make them confident and knowledgeable. Don't take away their confidence कि ये अब जैसे अभी आपने ये eclampsia kit दिखाया, इसमें laryngoscope, बहुत सारी चीजें हैं, but that is the main thing, that the Maxer, Lobetalol, hydrology, initial support measure, वो होना बहुत ज्यादा जरूरी है, so that we give the best thing in the first 15 to 20 minutes. Then the expert come into the picture, and this is like my takeaway, that for expert we should be very compassionate to every sort of system, because we want to save lives everywhere. So that is my takeaway.
Thank you for that comment. Yes, ma'am. And definitely patient should be managed in HDU or ICU if your facility has that. So thank you, ma'am.
Yes, and primary care is very important. We want to prevent complication.
Yeah,
like we don't want complication. We want to prevent complication. That is because yes, you bleed, you like sweat in peace, then you don't bleed in war. That is. Thank you.
So thank you, organizers, for giving us this opportunity. Thank you from me and Mala. Thank you, ma'am. Thank you, Ragini, ma'am.
Thanks, Madam Dr. Sadhna, for the comments.
Yeah, thank you, Dr. Mala and Dr. Anita, for wonderful presentations. And I just wanted to give one comment. These patients who are coming with eclampsia, they should be strictly monitored for abruptio also. They are at very high risk for abruptio.
Yes, fetal consideration should always be there, and
yes, we have to keep a very close watch for abruptio, and once it is diagnosed, we have to immediately deliver.
Yeah, both mother and baby become relevant.
One more thing, Anita, when you had asked, I think one important thing, we should also give the message that once you have given the loading dose, is very safe to give, but once you are giving maintenance dose, by that time we should have the creatinine levels for the patient, because so many patients are having a deranged KFT. And besides monitoring the urine output these days, lot of patients we are seeing in tertiary care who are also, having some features of toxicity. So having a creatinine level is very important. At least in the tertiary care, we should always take a creatinine level before we start giving our maintenance. So if
that way we will delay the second, dose intramuscular.
No, you will not delay, because creatinine, I think in emergency, no, you give the first maintenance.
Do the dose adjustment regarding that.
Yeah, for dose adjustment. So try to have it as fast as possible. I am not saying that don't give the maintenance if you suppose don't have creatinine. If and the urine output is normal and the knee jerk is there, give the maintenance dose, but try to have the creatinine level as soon as possible. Because
Thank you. That's a nice take-home message. Thank you, Dr. Jyotsna.
Yeah.
Dr. Sadhna, I just wanted to ask, the role of NASG should be there. It should be there in all ambulances, at least for the transferring a patient.
Yes, NASG is what we can say, it is a very cost-effective thing. It can be reusable, and in certain situations, especially in the referral, actually it is for the referral.
In Tamil Nadu,
that it reduces, it reduces amount of bleeding, and we must, that is the minimum training, how to put all the 6 garment and how to reopen it.
In
But
Tamil,
it is a good add-on to our system. One concern about it, to be very practical, because we are today having a very, very heart-to-heart discussion. Sometimes it comes to my mind that when we need the primary aggressive measure in PPH, like the resuscitation, putting it, kabhi kya hota hai, when we took it, the NASG at the main front of our thought process, it is
it should
a natural thing. Yes, कि paramedical उसको पे ध्यान ना देके resuscitation पे और लगे उसको NASG में time waste करे. So it is a very good thing, very economical thing. It reduces it maintains the vitals of the patient, and I think it is costing around 2,000. I have also got 1 or 2, and we have donated to few, and it should be especially in the PSCs and CSCs where the patient is being referred. That is very important. In private hospital, it may or may not effective, because just we are shifting from
especially
I just
for
want to add
referral
2
patients.
things, Dr. Promila. I just want to add 2 things. This NASG, there are 2 main important roles of NASG. Are this one, as ma'am has said, for transfer of the patient.
Yes.
So it should be
Mainly
there
in
at
the
every
ambulance.
PSC or CSC. And second, when there is a busy OT and one patient is waiting and another is in OT, and both the patients are sick, then the second patient who is waiting can have an NASG free. So it is basically life-saving garment.
Yes, it's mainly for transferring in an ambulance.
And in Tamil Nadu state, the state government's criteria to keep a NASG in every ambulance where they are transferring pregnant women.
And we can also advocate for it. Promila, actually it is a advocacy also. Tamil Nadu, what was the Jayalalitha and advocacy, that we have quite a good system even at the PSC and CSC for women.
And the cost is 6,000 rupees.
Yes, so we can have a strong advocacy. It is a simple investment, like government, and as a professional, we should be strong voice.
It's a very cheap investment for saving a life.
Yes. Thank you for Promila. And it is for everybody. It is not only the PPH. Any patient who is having shock, it is useful.
Somebody was asking about which suture material is used for internal eyelid. It is #1 silk, which I use. And remember one thing, it is the 3rd biggest vessel of the body. So when we ligate the internal iliac artery, we do never cut it in between. Suppose in case it retracts, then there will be a heavy bleeding and life may be lost. So internal iliac is just ligated, never cut.
Thank you so much.
And regarding SR cannula, it is not evidence-based. And regarding Dr. Piley's clamp, it is very useful. And in fact, we had invited him in our workshop also. But I just wait that it should be mentioned in major guidelines. WHO and FIGO should accept this and make it evidence-based.
Actually, I will have this comment.
Otherwise, it is very good.
Shashi, SR cannula is very good, especially where it has evolved in a very low resource setting. What is a low resource? So we must be a little confident about our people also, because Western world ignores too much. It has ignored our Saint-Romain. It has ignored many things. So this is one very, very important concern when I'm contesting for FOGSI president, that we must honor, we must take consideration and do something to create our own evidence, because not only Shashi, it is India, mein ye question come hai. From Brazil, for many, many countries, they are questioning too much, that it don't push them for the impossible thing. So SR cannula, what Promila says she is using, she has a good collection, and we don't say it is evidence. That's why we did not take today. But if it is available, it may work any days, any time. So it is like in a basic medical science कि वहाँ पे section है, वो contract होगा, blood clot evacuate करेगा, uterus detect करेगा. It is just a basic science, and evidence का issue ऐसे आता है कि sometimes they really overlook many things. And so yes, we didn't to take it today, but let's keep all the aortic clamp is also not that evidence, but they will push the triple P, which is not very practical, but our aortic clamp, they put the question mark. So be aware for many things in the world actually.
Thank you. Thank you so much. We come to the last session of the day, that is drill for sepsis. Dr. Deepika, for that I would like to invite Dr. Jyotsna Suri and Dr. Rekha Bharti. Dr. Jyotsna Suri is Professor, Department of Obs and Gynae, Vardhaman Medical College and Safdarjung Hospital. She is in charge of Critical Care Obstetrics, Vardhaman Medical College and Safdarjung Hospital, Vice President, AOGD 2021-22, and National Corresponding Editor, HOGSI 21-22, Chairperson, Safe Motherhood Committee, Chairperson, Multidisciplinary Committee, and she has...
Thank you, Dr. Promila. You can
multiple awards and publications to her credit. Welcome, Dr. Jyotsna.
Dr. Rekha.
Yeah. The next speaker is Dr. Rekha Bharti. She is Professor, Vardhaman Medical College and Safdarjung Hospital. She is Editor, AOGD 2021-22, and member, AOGD Endometriosis Subcommittee and FOGSI HIV Committee. Past Editor, Narchi, Delhi branch.
I think, ma'am,
welcome, Dr. Rekha.
Yeah, thank you so much for the introduction.
Yeah. Thank you, Dr. Promila. Thank you, a very big thank you to Dr. Ragini for having us over here today, and to Dr. Promila and all the organizers. So this is a very important topic. We will be talking about maternal collapse today. So Dr. Rekha and myself, we have divided the session. First, I'll talk about what is maternal collapse and how we should, respond to it in a general way. And also I'll discuss some of the common causes of maternal collapse, and one case I will just tell, which we managed in our hospital. And in the second part of this session, Dr. Rekha will show how we are actually doing the resuscitation in a pregnant woman. So that's how we will be discussing and carrying on with this topic for today. So I'll just share my screen. Okay, so a very good evening to all the participants who have been part of this session and who are waiting till the end. I hope this session will be useful and you will be able to use this knowledge for management of your patients. So talking about maternal collapse, what is maternal collapse exactly? It is an acute cardiorespiratory or neurological event which can take place, for any woman, be it a low risk or a high risk woman. So this is something unexpected which may happen in the last month of gestation or the first few weeks after delivery, resulting in reduced or absent consciousness, potentially leading to death of the patient. This is the RCOG definition of 2020. Now, what are the causes which can lead to the sudden maternal collapse? So if we see this figure, every part of the body practically can be affected, right from the brain to the heart to the liver, whether it is a local in the uterus, the sepsis, then endocrine causes like hypoglycemia, diabetic ketoacidosis, aortic dissection, anaphylaxis, so all these causes can be there. So if we talk about, when the sudden collapse takes place, so what are the things which, can help us to organize our thoughts? There is a mnemonic, which is the A, B, C, D, E, F, G, H. So this has been given by the American Heart Association specifically for cardiac arrest during pregnancy. So A would be for the anesthesia complications. B is any bleeding, which is one of the commonest cause of maternal collapse. It could be antepartum hemorrhage, it could be rupture uterus, it could be postpartum hemorrhage. So all these are the bleeding conditions. Then any cardiac condition, any drugs, any anaphylactic reaction, or as we were just talking about magnesium sulfate, magnesium sulfate toxicity. So D is for drugs, E is for embolism. Embolism could be either amniotic fluid embolism, or it could be pulmonary embolism, or even air embolism, if any procedure has been done. Then F is for fever, which of course may signify sepsis. And G, the general conditions like electrolyte imbalance or hypoxia, and H is for hypertension. So this is for pregnancy, but specifically when we are talking about, causes of collapse, the ACLS protocols and all, so there they talk about 4H and 4T, which is for the general population also. So here the 4H signify for hypovolemia, hypoxia, hypo or hyperkalemia, hypothermia or hyperthermia, and the 4T is for thromboembolism, toxicity of any drug, tension, which is actually signifying tension pneumothorax, or tamponade, cardiac tamponade, or that is how, the causes of collapse in the non-pregnant have been classified. So we can use both these systems if we want to remember. So if we talk of the common causes of maternal collapse, we can divide them into the hemorrhagic and non-hemorrhagic. And I think amongst the hemorrhagic causes, since collapse is much more common in the postpartum period, the first 1 to 2 hours after delivery, they are the most crucial for a woman. And PPH, rupture uterus, broad ligament hematoma, hepatic rupture, subcapsular liver hematoma, these are some of the causes, hemorrhagic causes of maternal collapse, which we have to keep in our mind when we are, resuscitating or caring for a woman who has undergone a collapse just after delivery, and we suspect that she has lost blood, she's pale, she's in hypovolemic shock. So amongst the non-hemorrhagic causes, the most common cause is the septic shock. Then there can be amniotic fluid embolism, which has a typical triad of hypotension, hypoxia, and bleeding. Then there could be acute uterine inversion, eclampsia, a CVA, pulmonary embolism, heart failure, metabolic cause like hypoglycemia, electrolyte imbalance, diabetic ketoacidosis, and again, as I said, drug toxicity or anaphylaxis. So now the important question, can women at risk of impending collapse be identified early? So in the first slide only, I said that this can happen with any pregnant woman. It may happen even with the low risk women. But yes, there are some women who are high risk and in whom we can anticipate that there can be a problem. Already if they are diagnosed as a heart disease, or they have come to us with chorioamnionitis, eclampsia patient, that they could be having any kind of a problem like this when they are with us, when they are undergoing the labor or in the postpartum period. So, but there are also a subset of women who may not have any warning signs, and they may just collapse. So, however, it is recommended that we must use an obstetric early warning system in all cases to allow recognition of women who become critically ill. So it has got a low evidence, but this is the recommendation from the RCOG guidelines, which talk about the maternal collapse in pregnancy and puerperium, which were published in 2019. And they also say that early warning signs may be inappropriate to effectively predict all outcomes. So as we were discussing, so, this is the early warning system which is followed, and our previous speakers also spoke about the early warning, system. And most of us have got some experience of using these scores. So this is the most basic of the score, in which, this is color coded. So if there are all the physiological parameters are there and their normal values are given, the yellow alert and the red alert. So if the physiological parameters, they fall, one yellow alert is there, then it is recommended that repeat the observation in 30 minutes. If there are 2 yellow alerts or 1 red alert, then call the obstetrician and repeat observation in 30 minutes. And if there are 2 yellow alerts or more than or equal to 2 red alerts, immediate review by obstetrician and repeat the observation in 15 minutes or continuous monitoring. So the importance here is that whether it is a yellow alert or red alert, anytime you have 2 or more red alerts, it is a very significant finding. And if there are more than 2 yellow alerts, that is 3 or more, again, you should be having the patient on continuous monitoring. So this has been developed in the UK, where it is a midwife-led system. So that is why it is called the obstetrician. In most of our country, at least in the cities and in the towns, we have got most of the time the obstetrician is there in all the centers. But yes, at the primary level, this kind of scoring system is very, very important for quick referral of the patient and for calling the necessary help, because there also many times it may be the nurses who are managing or a medical officer who may not be a trained obstetrician. So these are very important, at least in the primary and the secondary level healthcare systems, even in our country. And there is another Cardley score, which we have been using in our hospital also. We have done studies also. So here this early warning score has got the, it is along with color coding, it is also got a score. So a discrete number is given to each finding, whether it is on the higher side or on the lower side. And then aggregate of the score is calculated. And then accordingly, the response is recommended, that if the score is 1, 2, 3, if it is 0, then it is normal. If it is 1, 2, 3, then if the patient is in a secondary healthcare, she should be referred. And if it is 4 to 5 score, then she should be referred to a tertiary care. And if it is more than 6, then she should be cared in a HDU or a ICU. So this is the importance of this score. Now I'll talk about what are the principles of management. So that is, basically any kind of collapse at that moment, either you may know what is the reason or you may not know, but the principles of management remain same, and that is the initial resuscitation. So Dr. Rekha will discuss about these, in detail, but I'm just telling you an overview that when there is a resuscitation, it always has to be a multidisciplinary and a team-based care. And we have to take care of the hemodynamics and the respiratory support. So the fluids, vasopressors, and on the other side, it is the oxygen, advanced airway, or the mechanical ventilation if indicated. And side by side, a focused history, examination, investigations have to be sent, and we have to ascertain the cause of collapse. So the initial step is you check for response from the patient. If she is responsive, you place the patient in the left lateral position and continue your further assessment. If she is unresponsive, call for help. And if the patient is not breathing or gasping, or there is no carotid pulse, assume that she is in cardiac arrest and begin the high quality CPR and displace the gravid uterus manually, left uterine displacement, which Dr. Rekha will tell in detail. Now, if you are going to talk about the differential diagnosis of collapse, I have told you the causes, but just to, the very common ones which we see. So how do we connect to them? What could be the cause? If you have to quickly in your mind revise, what is the way that they will present. So amniotic fluid embolism, which we all are very, very scared about, because it can happen with any woman, So it normally, amniotic fluid embolism is a sudden collapse, which will take place during labor or within the first 30 minutes of delivery. And here the patient will have she can have hypotension, she can have hypoxia, and along with that, within few minutes, she may go into DIC and have PPH, and she may have also seizures. So neurological complications are also there, along with DIC. So that is a very typical condition, the amniotic fluid embolism. And the Society of Maternal Fetal Medicine has actually now given the, the clinical diagnosis, how to diagnose this condition. There are 4, criteria which have to be met. So it is a very, very now, because we don't really much, because it's rare, we don't have much experience. So there are no real guidelines about diagnosis. But lately with this, document from the Society of Fetal Medicine, we are now more in a position to be medico-legally safe also when we are suspecting amniotic fluid embolism. Acute pulmonary embolism normally will not take within the first few hours after delivery. It normally occurs in the first 3 weeks. We see mostly in women who have got the risk factors for pulmonary embolism. And in such cases, if you ever suspect that, mostly it will take place, what we have seen in our own experience, it is mostly in our post-operative cases, or in cases who are having, sepsis, or who are having high blood pressure. Those are the very high risk patients. And any woman who is having, a breathlessness, sudden onset breathlessness with no previous history of heart disease and unexplained, you can very well suspect that it could be acute pulmonary embolism. And of course, you should investigate with a compressive ultrasound, and if required, a CTPA. So the CT pulmonary angiography is actually the gold standard for diagnosis. But pending these investigation, if you have got strong suspicion, don't wait for diagnosing and start the treatment immediately, because it will be life-saving for the patient. Acute pulmonary edema, again, the background is there of heart disease, preeclampsia, hypertension. So here, the typical picture will be there: the frothy sputum, the cough, the breathlessness, and she's relieved on sitting. You will have the typical fine crepitations at the bases. So I think most of us are able to diagnose acute pulmonary edema. Cardiogenic shock with the history of heart disease, it is very, significant that she could have gone into cardiogenic shock with a low BP. There can be a sudden collapse when the contractility of the heart is very poor. So here, urgent echo, bedside echo is very, very invaluable for the diagnosis in such cases. And pro-BNP, which is a cardiac marker, and TROP-I and TROP-T, these can actually help us in diagnosing a cardiac problem. Air embolism is also a catastrophic cause of collapse. Mostly, if the patient is having some procedure like a CVP line insertion in the OT or in the HDU, and she has a sudden collapse. So this can be one of the reasons. Aspiration is unlikely in a conscious patient, but yes, if the patient is having altered sensorium and she has suddenly become dyspneic, you can suspect aspiration. Uterine inversion is again a common amongst obstetricians, one of the causes of, not I would say common, but yes, a cause of collapse. So always after delivery, if there is a collapse, along with ruling out PPH, please don't forget to palpate the fundus and always do a PV to rule out a uterine inversion. And also highly recommended is that concealed, hemorrhagic shock has to be ruled out. So rupture uterus, any hematoma, broad ligament hematoma, or a liver subcapsular hematoma or rupture, or splenic rupture. So these are the things which urgent ultrasound is required to rule out if there is a case of collapse. So investigations, mostly they are the conditions I have spoken about. So they will be, important to rule in or rule out the ABG with lactate and electrolytes, because the point of care ABG, that gives the electrolytes. So if it is a hyperkalemia or a hypokalemia, something which has led to collapse, you get this electrolytes immediately. Lactates will be high if it is a hypoperfusion and in sepsis. X-ray chest will give us so much of information if it is a pulmonary edema, ARDS, pneumothorax, consolidation of the lung, etc. ECG, echocardiography for the conditions of the heart, point of care ultrasound, as I just discussed, abdomen, pelvis, chest, all we can do. And if you think about a CVA, then a NCCT is good enough at that time in the emergency. Along with that, we have our other routine investigations for hematology, KFT, LFT, DIC profile, sugar, very, very important. Please don't forget to do the blood sugar levels. They can be, hypoglycemia as well as diabetic ketoacidosis. Both are very common causes of collapse, especially in women nowadays, with such an increase in the incidence of diabetes in pregnancy. We are seeing in our own institution, we are seeing very often now cases of diabetic ketoacidosis also. So don't forget to do the blood sugar. Urine ketones, of course, if you are suspecting ketoacidosis. Pro-BNP, again, part of our cardiac panel, and pro-calcitonin if you are suspecting sepsis. And of course, the cultures will be there in that case. So if you just see this table, it is giving you an overview of management of some specific conditions like anaphylaxis. If you are suspecting you have given some antibiotic or some drug and she has suddenly had stridor and wheezing, and then there is some collapse, so BP falls. So you can think about anaphylaxis. And don't forget, this is what was taught in MBBS, but I see that most of us forget it by this time. So 0.5 ml IM is the dose for anaphylaxis. Adrenaline is the drug of choice. So please keep this ready in your emergency trolleys at all times. For magnesium sulfate toxicity, it is 10 ml 10% calcium gluconate IV slow. So we diagnose magnesium toxicity, to the extent that most of the guidelines say that if there is a sudden maternal collapse and the patient was receiving magnesium, we don't wait for anything or any test, you just give the calcium gluconate, because it has been so, the association with a sudden cardiac arrest or a cardiorespiratory arrest is definitely there with magnesium toxicity. So if your patient is receiving magnesium, you can, you are totally justified in such situations to give them the calcium gluconate. Sepsis, you have to follow the 1 hour sepsis bundle, which I think we have been stressing on this in various forums. So it's eclampsia, we have already discussed in the previous sessions. Pulmonary embolism, start the heparin or the low molecular weight heparin immediately. Uterine inversion, we all know manual reposition is very important as early as possible. And of course, supportive care, you have to give the patient, she may be in shock, neurogenic shock, you have to give her the fluid resuscitation also. And if she's having PPH, you have to give the uterotonics. So cardiac failure has to be managed with the multidisciplinary approach. You need a cardiologist or a physician with you. And inotropes are very important here. And of course, the patient may need a ventilation. The amniotic fluid embolism, again, supportive care is there. There is no specific management for this, but a multidisciplinary supportive care. And because we expect the PPH to take place, so we must arrange our FFP cryoprecipitate in such cases, because it is invariably, if the patient will survive the first half an hour to 1 hour, PPH is something which we should expect in such cases. And CVA, if you suspect, again, you need the multidisciplinary support of the neurology and the critical care physicians. So one case of postpartum collapse, which we managed, I'll quickly go through that. So a 21-year-old primary gravida came as an unbooked case to us in emergency, and she was referred as a case of preeclampsia and received antihypertensive prior to referral. She had amenorrhea of 9 months, and she came with pain abdomen for 2 hours, headache for pain abdomen for 6 hours, headache for last 2 hours, blurring of vision since 1 hour, and leaking per vaginum since last 30 minutes. So on examination, she was at that time alert. This is the AVPU, which we use: alert, responsive to voice, responsive only to pain, and U is unresponsive. So this is a very simple system for neurological assessment. which we all can use instead of the more elaborate GCS, that is the Glasgow Coma Scale. So she was alert at that time. Her BP was high, 148/94. Respiratory rate was also high at 30 per minute. And her SpO2 was 96% on room air. At that time, when she came to us, she had the crepitations and urine albumin was 2+ on dipstick. So the diagnosis which was made was, and of course, when the PV examination was done, she was 6 centimeters with breech at station 1. So she was a breech presentation. So the diagnosis of primary with 36 weeks pregnancy with breech presentation, with pre-eclampsia, with pulmonary edema, with impending eclampsia in active labor was made. So this patient was managed. She was immediately in the emergency room. She was catheterized, cannula was put, oxygen was started, Lasix was given, Maxell loading dose was given, and all her samples, ABG, etc. were done. And patient in the meantime was in active labor. She was transferred to the labor room. She delivered a 2.1 kg baby, and immediately after that, she was transferred to the obstetrics ECU for postpartum monitoring. So the first 6 hours after delivery, the patient was stable, but she suddenly collapsed with a BP of 76/44 millimeter after 6 hours. And at that time, her saturation dropped to 68%. She was immediately intubated and ABG was done. So at that time, the ABG showed a severe metabolic acidemia. We can see the pH was 7.0 and her the respiratory rate here 14. And yes, so what I want to show that the bicarb was very low. It was only 10.2, and her glucose here on the ABG, it was 298, and with a high anion gap of almost 18. So we made a diagnosis of wide anion gap metabolic acidemia with respiratory acidosis, and it was a case of diabetic ketoacidosis. So this was what we found in her ABG. And we repeated the because we thought that maybe because she had no diabetes and no history of diabetes, and previously when she had come to hospital, the sugars were around 145 or something as a random check when it was done. So here we repeated the RBS with glucometer, it was 500, and urine ketone by dipstick was 2+. So if you all recollect the diagnostic criteria for DK, number 1, urine ketone should be +2 or more. The blood glucose should be more than 200, or the patient should be a known diabetic, and bicarb should be less than 15 and pH less than 7.3. So all these 3 criteria were fitting, and we made the diagnosis of diabetic ketoacidosis. So the resuscitation for her was done, and saline was given 1.5 liter over the first 2 hours. Her hyperglycemia was corrected. We gave her 6-unit IV bolus dose of insulin, followed by 4 units per hour, and glucose was started every hourly. And when it became less than 200, it was decreased to 2 units per hour. Correction of the electrolytes, especially the potassium, was done. Regularly we gave her the 20 milliequivalent of potassium in her IV fluids, and acidosis was corrected with the bicarb, and she was strictly monitored. 2 hourly electrolytes and ABGs were done. So input output was done. So this is the ACOG 2018 the management chart which has been given. So the cornerstones of management of diabetic ketoacidosis in pregnancy are the IV fluids, electrolyte management, insulin, and of course the bicarbonate. So this is all that are the drugs which we require for management, the IV fluids and the soda bicarb and the insulin. And of course the bicarb we had to correct here because it was less than 7.0. So how we did the correction, I think all those things I will not go into the details over here, but this was a typical case of maternal collapse. And here I highlighted this because the glucose when she came to us, it was normal, but she was an underlying diabetic, and the stress of the eclampsia and the the labor, and she just actually went into a diabetic ketoacidosis state. So it was something which was very surprising for us also. And however, it was a reversible condition, and the patient was discharged alive with her baby after about 8 to 10 days of hospital admission. So to conclude this session, I would like to say that any pregnancy can become high risk with severe outcomes, and the obstetrician should be trained to recognize maternal collapse and promptly initiate the resuscitative measures. You can remember the causes of maternal collapse by 4H and 4T or by the ABCD approach. The most important causes are related to hemorrhage, hypertension, and sepsis. The initial approach, whatever may be the cause of collapse, is to stabilize the patient and then to manage the specific condition. And because collapse is not a frequent occurrence, regular institutional drills are very important, especially on the mannequins, because every time you may start, doing this, on a patient, you will do a lot of mistakes because we are not commonly dealing with such cases. So that's all I would like to do in this session. And I think I would like to call upon Dr. Rekha. She can continue the session and then we will have the discussion after that.
Yeah, thank you, Dr. Jyotsna. And now we'll just talk about, was one situation that we discussed right now, was that the patient was in the obstetric CCU and their patient collapsed, but there the pulse was there, the respiration was not there. And because the patient was in CCU, so she was immediately intubated. But now the situation which I'm going to take here is that you are there in your clinic and some patient comes to you and you find that the patient is collapsed. So this is what, we have been, now we are going to do. Generally, we would have liked to do a drill on this, but just because we are having it virtually, but I'll make sure that each and every step of the drill is covered here. So first of all, whenever you have a patient who is non-responsive, like you see the patient is unconscious, not responding, first thing is that we check for responsiveness. So when you feel a patient has collapsed, we actually do not know whether the patient is collapsed or what has gone wrong. So how we check for responsiveness, there are clear, guidelines, clear steps which are given. And I think we all should revise these steps so that we do not miss out on anything. That is why it is important to do regular drills also. So you have to face the victim and just on the shoulders, you tap and you ask them, are you all right? Aap theek hain? So this is what you actually do. And if you get no response, then first thing you do is you call for help. If you are in the hospital, very soon all the hospitals will be having a maternal code blue. Maternal code blue is when the patient is pregnant. If the patient is not pregnant, you do not need maternal code blue because you do not need someone to take out the baby to do the resuscitative hysterotomy. So just an emergency code blue will be enough in these cases. Now this is, first step in the CPR, which is told to everyone, that first check that the respiratory system, like there's no foreign body there. Whenever any patient collapses, and also this is a general thing which is done, you tilt the head, lift the chin and look for the foreign body. If it is there, you remove it. But in our patients, unless the patient, is aspirating or was eating something, like this happened in one of our wards, patient was eating apple and suddenly, it got stuck in her airway and she collapsed there. So that kind of situation might be there, but most of the time, you then go on to whether the respiration and pulse is there or not. So like how you check for respiration, and just one thing is that you do not waste time on here. So 10 seconds you take, in these 10 seconds, you are going to palpate for the pulse and you are going to observe the respiration. Now, how you check the respiration? First is that you look for the movements, listen to the breath sounds or feel for the breath. So these are the three things which we do to check for the respiration. And then simultaneously you feel the pulse. Now, which pulse? It is a carotid. We know patient is collapsed. You're not going to look for any other pulse. How you track the carotid is that you tilt the head with one hand and you use the fingers of the other hand, locate the trachea and gently slide your fingers into the groove between trachea and the muscles of the same side of the neck. So if you're not able to feel for carotid, don't waste your time. Just 10 seconds you have taken to observe the respiration and the pulse, move on to the next step. So now next condition that I'm going to take up here is that there's no breathing. You cannot feel the carotid pulse. Now, as Dr. Jyotsna also said, there could be agonal breathing. The patient is struggling to breathe, we say gasping. So these are actually not true breathing, but a brainstem reflex. So you should not confuse it with a regular breathing. If it is agonal breathing, means you have to give the respiratory support to the patient. So the next step would be that you give CPR in a ratio of 30:2. Now this 30:2 is a ratio for cardiac compression, chest compression, and the respiration. So now next thing is how we give chest compression. So for this, it is very important that you are kneeling on the side of the patient. So either, because unless you kneel on the side of the patient, you will not be able to give it in a, as you can see here, your shoulder should be right above the patient's chest. So this position you will not be able to achieve. So your patients won't be on the floor, but you can go on to the climb on the bed of the patient. And one very important thing, because our patients are on the mattresses. So when you are giving CPR to a patient who's on the mattress, it is a good practice to keep a wooden board which you can slide below the chest of the patient. This is what we do, and we have kept it in our obstetric critical care units where we have patients who are, going into cardiac arrest, and we do need to resuscitate these patients. So technique is very important. So it is, what you do is you actually, with both your hands, you fingers in between, you interlace your fingers, and with this heel of your hand, you are going to give the compression. So this is what is important. And where you are going to aim is in the lower half of the sternum. This is very, very important. The place which is chosen is correct. How many compressions we aim? We aim for 100 compression in a minute, and it should not be more than 120. And as we say, you can count it as 101, 102, 103. This way you can go to 1030, or you can just 1, 2, 3. So this, you have to, by drills, you have to see that how you're going to count this. Okay, now how much compression of the chest should be there? This is also very important, because unless you achieve adequate compression, the massage on the heart won't be effective. So it is at least 5 centimeters, which is 2 inches. Now here also, when you are giving it, at times you do not realize, if you go too deep, like if it is more than 6 centimeters, then you know that you may lead to some complications. So you should avoid. So that is why it is important to have hands on these, like do it yourself, to know that how much you have to give, how many you have to give. So this is one thing which is very important. Now in pregnant patient, as Dr. Jyotsna also mentioned, left uterine displacement is very, very important. Now you have to take the uterus towards the left side. Now how you achieve this manual displacement of the uterus? If you are standing on the right side of the patient with your one hand, as you can see in the above picture, you deviate the uterus. So this displacement, it is not that you just have to touch it. It has to displace from the midline, because our aim is to relieve the aortocaval compression. So to achieve this, it should be beyond the midline. So it has to be very firm left uterine displacement. And if you are on the left side of the patient, you can use your 2 hands and take the uterus towards you. Now, this depends upon where you stand, from where the cardiac compressions are being given. So you have to be on the other side of where the cardiac compressions are being given, so that you do not interfere with the person who is giving the cardiac compression. So now the third thing which we are doing is bag and mask. See, it is said that if there is one person to begin with, then what should you do? You go for chest compression. That is very, very important, very vital part. Patient is pregnant, left uterine displacement is very common. If you tilt the patient by, like previously, we used to say just tilt the patient, put some support below the back of the patient, so the patient is tilted and the uterus goes away from the aortocaval area. But there, the compressions won't be effective. So it is better that you displace the uterus manually rather than tilting the patient. So now this is the technique of giving the bag and mask. Now, if you see the operator, how the person is giving, you can just see the one with the thumb and the index finger. This is the compression which is on the mask, because you have to keep it compressed with the face of the patient. And then you see the E. E is the elevation, which is by the 3 fingers, the little finger, ring finger, and the middle finger. So they are basically elevating the mandible. At the same time, your thumb and the index fingers are compressing onto the this bag which you have. So this is the compression and elevation, C and E technique which we use to give the respiration. And as we said, after 30, you are going to break and give 2 breaths to the patient. And then again, the chest compression starts. So 30 again is given. So if you see, if you are, just initially placing the mask on the patient. So as we said that this, you just tilt the head, lift the chin, place the mask over it, then you maintain. So this is one position that there can be 2 people doing the giving the respiration. So here one person can hold the this mask onto the face and other person can just press the bag. So this is 2 people giving the respiration. So if you have more hands in there, then you can go for this also. But if you are short of hands, then C and E, and the one person only can press the bag. So you don't need a second person here. Then second thing, as I mentioned, till you have defibrillator available. So now this is also very important. Nowadays, we do have defibrillators available almost everywhere. So what is the purpose of taking this defibrillator is that you get to know the type of rhythm. So mostly, our patients have non-shockable rhythm, but patient, if she's a cardiac patient or some other problem, you may even have a shockable rhythm. Shockable rhythm means either there is ventricular tachycardia or ventricular fibrillation. So how you get to know it? If you have the automated external defibrillator, there it will give you the verbal command that it is shockable or non-shockable rhythm. If you have the conventional semi-automatic one, there, when you keep the pedals on the patient's chest, you can see on the monitor the heart rate of the patient. If it is flat line, that means it is non-shockable. Just remove the defibrillator pedals and continue with the chest compression. If you see the ventricular fibrillation or ventricular tachycardia, that means you are going to go in for the shocks. How much shock we deliver? Nowadays, we are using biphasic kind of shocks. So we give between 150 to 200 joules only. So this is the only thing which you are going to give. Now, how to place your paddles? This is also very important. So as you see in this figure, one paddle is placed on the right side, just below the clavicle, and the second paddle is placed on the left side. This is below the nipple. This is over the lower costal margin, just anterior to the anterior axillary line. So this is the place where you're going to keep your pedals. So if you have the semi-automatic one in which you are going to operate by hand, this is the placement of paddle there also. And this is the AED where you have kept you stick these electrodes onto the patient's chest. Now, first thing, we check the rhythm. Then the shock which we are giving is same as in the non-pregnant women or patients. Then you give 2 shocks 2 minutes apart. Now, important thing is when you give shock, we all know that you have to see for the safety of your team and yourself. So you move away, just keep the paddle on the patient's chest, move away, and you just say, I'm clear, you are clear, everyone is clear. Just look around. If no one is touching the patient or the bed of the patient, deliver the shock. So this is how it is done. And immediately after delivering the shock, it is important that you resume CPR. You resume the chest compression first. So this is very, very important. And now, how would you get to know that patient is, that pulse is returning? That every 2 minutes you look for carotid pulse. So it should not be earlier than 2 minutes. Every 2 minutes you look for the carotid pulse. Now, third very important thing in pregnant patients is that these is the drugs which are given in all the patients. The important thing, madam has already highlighted, so I'm not going to go in detail of it. The only thing which I'll just stress upon again is that you always give IV drugs in the upper limb and you take limb above the level of the heart. This is very important for the delivery of the drug. So this point should not be missed out. Then now we come to perimortem cesarean section. Now it is said that within 4 minutes, like if the patient has not, if you are not able to revive the patient, then you should proceed with the perimortem cesarean section. So you start planning it 4 minutes, you cannot palpate the carotid pulse, you start planning. So within 5 minutes, you are able to take out the baby. So you do not need much instruments. You just have to have, and this is a part of the crash cart which is kept in the obstetric wards or in the labor rooms or in obstetric CCU or in the obstetric emergency, that this cart must have instruments to do the resuscitative hysterotomy. So here, you just pour the antiseptic solution over the patient and just put a sheet over the patient and give incision. So incision, because you want to do it very fast, so generally you give vertical incision, and even you do the classical cesarean section. So it just depends upon your choice, just that you have to deliver the baby very fast, and you just deliver the baby. Do not touch the placenta. This is very, very important, because patient is hypoxic. Even when the patient returns, this if you have removed the placenta manually, all the sinuses are going to bleed. She will die of PPH. So leave the placenta there. Continue with your CPR. If you are able to revive the patient, shift the patient to the OT, and there you suture the patient, wait for the delivery of the placenta, give uterine massage, give the drugs, uterotonics, and then only you remove the placenta and do the suturing. Now, if you are able to revive the patient, the next important thing is that you put the patient in the left lateral position and recognize and treat the cause. If patient was, there was no pulse, no respiration, you didn't have the time to look for this. Although it depends upon your team, how much team you have. One person may just go ask the relative what happened, what was the sequence of events and all, and explain them also the patient's condition and the need for resuscitative hysterotomy if required. You do not need a written consent here. So now what is important is what is the recovery position. So if you actually see this diagram, it is very easy that first the hand which is on your side, you just take it at 90 degrees. So you arrange this hand at 90 degrees. Then you take the other hand and put it on the cheek of the patient. So on the cheek of the patient, which is on your side, then what you are going to do is you are going to bend the leg at 90 degrees and keep your one hand over the hand which is on the cheeks. This is just to keep the patient stable. So as you are turning the patient to one side, patient should not slide towards you, should not just move away from this position just to stabilize the patient. You have to keep this hand. Then after bending this knee, you just turn the patient. Even if patient is very heavy, if you are following these steps, it is very easy to assume this recovery position. So after that, you will have some help reaching there and patient can be taken over for further care. Now, one thing which situation which we discussed right now, that carotid was there in the previous case which Dr. Jyotsna discussed, the patient was not having breathing. So here, till you have anesthetist arriving, because in pregnant patient, intubations are difficult. So we are not attempting intubations ourselves. We can just go with the bag and mask ventilation, and we can use 100% oxygen at more than 15 liters per minute. And but one thing is that check for the airway obstruction and go ahead with bag and mask. Now, carotid is there, breathing is there, patient is not responsive. Put the patient in the recovery position, assess for the respiration, pulse, BP, and then you look for the fetal heart also, identify the cause and treat the cause. So this is, in brief, how you go about. And I'll just show you one chart, which we generally, keep in our critical care areas. That this is, one chart where we just have written like how you go about. So whenever a person is there on duty, it is better to have such kind of charts so that you can, keep revising your steps, that how you have to go about it, like how much shock you have to give, if it is shockable rhythm, how you give. And this very important step of left uterine displacement is not missed out. And the causes also are there highlighted. So, quick, you can just have check of these things also here. And this is, one thing which we can do in our critical care areas, emergencies, and even in labor rooms, we can have the patients going into collapse. So all these things should be available at all the areas in obstetrics. Thank you so much.
Excellent, Dr. Rekha.
Thank you, ma'am.
Hello, Dr. Jyotsna.
Hello, hello.
So we have 10 minutes to go. If anybody wants any question, can you put in the chat box and our speaker will ready to give. Any speaker want to give any inputs for anything, please go ahead and give it.
Dr. Rekha, please clarify, you had highlighted that you just, during perimortem cesarean, just take out the baby, leave the placenta there.
Yeah.
So then, yeah, please elaborate on this point.
See, you just take out the baby, clamp and cut the cord and cover the patient's abdomen with the sheet and continue with your resuscitation, CPR. If you are able to revive the patient, you take the patient to OT and suture the patient there. As we all know, once the patient has been revived, the heart has returned. So mostly respiration takes some time to come. So they intubate the patient. And after that, the patient is shifted to OT. And there, you just give fluids, arrange blood in the meantime, and then give uterotonics, and then only see for whether the placenta is separated, and then only you take out the placenta, because there the uterus is atonic, because patient is hypoxic. It is just a bag-like thing. You don't have to look for that also that placenta is separating or not. Just cover, because your main aim is to resuscitate the patient. So whatever has to be done, delivery of placenta, suturing, that will be done in OT if we are able to revive the patient.
And if we have a separate team, Dr. Rekha, if a team will take care of the CPR, then the obstetrician can go with the removal of the placenta and continue the suturing?
Ma'am, actually, just to tell you one thing, because this happened, initially when you do things like this, so somebody just took out placenta and patient started bleeding. So, the moment this circulation starts coming, when the circulation is not there, patient will not bleed. And the uterus is not contracting, so placenta will not separate. So it is better to leave it there at that time.
So this is really important to know. We are preventing the unnecessary hemorrhage in the patient.
No, the important thing, what Dr. Rekha is, I think, given very clear messages, that the baby is removed for improving the compressions, improving the cardiac output, and improving the chance of revival. Placenta at that point of time is not important. We have removed the baby. With that, you decrease the pressure on the inferior vena cava, which improves the cardiac output. Your compressions become more, they become more effective. They become more effective, because if you are doing it with the weight of the baby, even when you are doing the left uterine displacement, still, you are not achieving a cardiac output, which you do in a non-pregnant when you are doing CPR. So you are only getting about 20 to 25% of that cardiac output. So to achieve the maximum, you remove the baby. That's why it is now called the resuscitative hysterotomy rather than a perimortem cesarean. It's part of all the guidelines for resuscitation of a pregnant woman. And we are not obliged or bound to take consent for it separately, because it is as much a part of resuscitation as a intubation. So when we are not taking consent for intubation, because when the patient collapses, you are not running to, you will definitely tell. But at that moment, if you are alone, your first focus is to resuscitate the patient rather than going and running and taking the consent. So that is the way, it is part of resuscitation. So placenta is, don't fiddle is the message. Leave it alone. Our purpose is to take out the baby. We have done that. And then you just cover it with a sterile, gauze or whatever is there, available, and leave it. Just leave it at that point of time. So
Dr. Jyotsna, your comment for the documentation of the whole scenario.
Documentation.
How you do the documentation in your hospital when it is happening? Who does the documentation? How we continue to be the documented each and every step at the same time or after?
No, documentation. See, if we are a team, definitely we have a person who will document, who will go talk to the relatives, and who will, in fact, take the consents also that this is happening and we are doing this, give the minute-to-minute information also, and they will also document whatever is going on. But if you are not, the team is small and all of you are focused on resuscitation, you will document it at the time when your work has been done, when you have done the resuscitation, because at that time, if you are limited human resource, precedence is the resuscitation. Documentation is all there in our head and we have to document it. Definitely we have to do it in a very, very organized way. we will be documenting it. There is no doubt and there is no shortcut for documentation. It has to be
So I
done.
think what coming in my mind is just a food of thought after listening everything, that in a smaller places when we are one person and one or two nurses, should we have some audio video recording type of system in the room which is be on at that time and everything is recorded, then we can do the documented one by one, because it will save us in the court of law.
Ma'am, actually, if we go too much for audio video recording, one is the privacy of the patient, you know, if it is a video recording, we don't keep actually cameras where the patients are there. Second thing is the audio recording, because at times, you know, we all understand that some chaotic thing is going on. But here it is very important, as you mentioned, that whosoever is in your labor, because CPR is not only for doctors or sisters to do. Nowadays, even general public is being trained. So all the paramedics, everyone, even your guards who are there, we actually have to train them. And whosoever is there, we all have to be knowing that we'll need 4 or 5 people at that time. So we should have a team and everybody should be trained, so that, you know, one person cannot give chest compression for more than 2 minutes. You have to change over after 2 minutes because it is tiring. So the people have to be shifting. And when you keep, and that's why drills are important, you know, so that everybody is involved when patient collapses. Then one very important thing is that as far as possible, when you have working hand, one person is keeping check on the time, because when you are all going, you know, so nobody remembers what time and all. So one person just check the time and tells you it is 2 minutes, check for the carotid. Now it is 4 minutes. So has the pulse come? If not, then go for resuscitative hysterectomy. So this we can achieve only if we do the drills. So centers where the larger team is not there, I think we should assign things to each and everyone who's around, that everyone is involved in this process. And time documentation is very important. Ampules, you can count how many you have given. And IV fluids, you know, when we attach, if you must have seen sisters keep writing 1, 2, 3, so that you remember the count, how many fluids have gone and all. So these are the drugs and the fluids which you are keeping a record of. Time record, one person keeps, because you have to be every 2 minutes checking the carotid, change over so that the person is not tired of giving chest compression. Then when it is 4 minutes, you have to start thinking of the resuscitative hysterectomy, and one person has to be ready doing it. And that's why we said nowadays, like, it is maternal code blue. Like if some mother is collapsing in some other department, you know, maybe she was admitted under medicine or was admitted under intensive care unit, which was not from the obstetric side, and there she collapses, the message which goes is maternal code blue. So all the team in the maternal code blue should be alerted. So this kind of a thing, all the hospitals, even smaller centers, should have at their places, that when you alert code blue, so your guards, your nursing orderlies, everybody knows this code blue is this, and whosoever on duty or on floor is there, they know this is my job when the code blue is there, somebody has indicated code blue. So this kind of a thing, you know, we have to reach. I think we'll take some time, but gradually, you know, this is what we are aiming at. And this is what is the aim of all the drills which are being there, and the people who are being trained. So even, you know, when they say you are there, and even in the public, there could be someone collapsing. So you know that you are good at giving chest compression. Just start with the chest compression. You have learned that. Respiration and all these things will start later. Because only if you're giving chest compression and one person, you may not have bag and mask. Though nowadays it is kept everywhere, even at railway stations, airports, even in the malls also, they even have AED also. So we are all should be trained in operating it, because if as doctors we do not know and we are training general public. So I think it is, you know, first we have to strengthen our own strength. Because the general public, if knows more than us, I think it is really for our profession we have to be. So as gynecologists, we can't say that anesthetists will come and resuscitate. Resuscitation has to be started there and then. You cannot waste time there. So each second is very precious when patient collapses in front of you. And very important is to train all your staff who's available, clerical staff, even your guards, even your paramedic staff, everyone should be trained in giving this CPR. And when we are in a center, we should tell each one their role. So when this happens, this code is, you know, being indicated, then you should reach there and start doing this. Your thing is to watch for the time. So that person is keeping the time. So guard, you can tell that guard, just keep the time, keep reminding us every 1 minute that now it is 1 minute, 2 minutes. So that is how, we can just aim for, and then later on we know everything, what was happening at this time, we were giving this. So drugs and all, you all have in front of you, vax you are numbering. So you can always document it later on. But just for the sake of time management, you should know that how much time is lapsing between your start of resuscitation and your further events which are taking place.
Yeah, that is why induction trainings are so important. Na? As soon as we are taking in our residents, even JRs, they should be told how to do basic life support. Everybody should know. It is our duty to train them. CPR should be known by all the staff, as very well highlighted
all the
by
doctors
Dr.
also.
These drills should be regularly done in all the labor rooms, in all the setups, and everybody should know the codes. Like somebody may say, what is code blue? Your staff should know what is code blue, as she has very well highlighted.
Yeah, for
one thing I will say,
learn all these things, Dr. Anita, because everybody, even our, as Dr. Rekha was saying, even the GDA and everybody should be involved, and they should also learn about this. Then only you get a NABH certification.
How many of us
All,
can do
for
this?
NABH certification, every member of the hospital, whatever is the capacity he is working in, has to be BLS trained.
Yes.
That is very, very important. I think for medical, persons who are working in a medical facility, it's our duty that we should train everybody. The BLS training should be there.
Ma'am, actually, English movies, mein hum dekhte hain, even on the railway platform, they do resuscitation, and everybody is capable of doing that.
Why not? We saw in that football match when that resuscitation was there.
Yes.
So it was that player could not have been revived if the players had not given resuscitation there and then on the field. So this is very recent. I think we all have seen this happening in front of us.
One thing I will really like to add a little bit I got to the hospital. One is to all actually, whenever there is a collapse, we are talking about all the things, the guard and nurses and everything, but we all know in our heart, whenever there is a collapse, patient can go either way, and that is actually holding us to taking courage of doing perimortem cesarean section, that everything will be very dramatic and how it will say. So I think, yes, basic life support we should know anytime, anywhere we might need it for anybody, but something very important, that train our staff, like PPH, we say na, identification of blood loss, that there are always the pre-signs of the collapse, like patient is suddenly vomited, patient is suddenly having a anxiousness, and that sign should be like, it should be like 1, 2, 3, 4, 5, and we don't want this collapse to happen, but we want to prevent the collapse and act at that time, that really we can have a very good survival. So one thing I will say, that always collapse, like we are talking, if we have our guard and nurses have the life support cardiorespiratory, we will able to always make them survive. क्योंकि ये कोड करेगा कि हाँ, हम सब लोग ऐसे बात करें ना कि अगर सबको आता है तो हम बचा ही लेते, but cause can be diverse, we don't know what is happening.
Absolutely.
So our really we should have that the pre-monitoring. Collapse भी कुछ बताती है कि ये होने वाला है, and patient is not on the monitor in post-operative period or just after delivery or before delivery, and nurses take a different viewpoint of that pressure. So I think that in our all peripartum collapse, we have that section very, very important, that we don't want to have complication. Train everybody in anticipating this patient is not looking good, and whether she is in OPD, whether she is in labor room, whether it is
monitoring the patient with a monitor during labor and at least 2 hours after delivery.
Early warning signs is what Dr. Sadhna ma'am is
stress on the stage 4 of delivery.
Yes, taking pulse and blood pressure itself is so important. Our residents, they somehow are not ready to touch our patients. It's
even
very
if you
important.
don't have big monitors, with COVID, everybody has a small pulse oximeter. At least the pulse will tell you. Patient ko tachycardia ho raha hai, so that's the first alert. You have to be very careful about that.
Pulse is a very important sign, yes.
So patient should be intrapartum as well as postpartum, 2 hours. Minimum the patient should be on pulse oximeter, and strict monitoring should be done.
We should
discuss
this thing with the patient also in the OP. These are the complications of the delivery which can happen with you even there is, you are a low risk patient. Only then they can
that's what
able
we
to
are saying.
understand this.
The low risk diagnosis is a retrospective diagnosis.
Yes.
Yes.
No patient is low
Obstetric
risk.
management
So it's a
consent
retrospective
up to the death.
diagnosis whether this patient was a low risk pregnancy or a high risk pregnancy. Yes.
For every patient, ideally speaking, we should take a obstetric management consent in OPDs at 34 weeks or 32 weeks up to the collapse and the death. Won't you agree with me?
I don't want to scare the patients.
scare नहीं, लेकिन उसको
speaking. Yeah. So I know as practicing doctors, what is the concern which you are saying? I can definitely empathize with you. But having said that, I think we have to be very sensitive when we are talking to a pregnant woman. As it is, there are so many things in her mind and lot of apprehensions. So it has to be in a very sensitive way. Of course, that definitely when the patient is admitted, we do take a consent from them for any procedure. There is a blanket consent when they are admitted, which includes any procedure which may take place in the hospital. So definitely it is all covered. If they are even slightly high risk, we give them, our residents are very well trained in taking all kinds of consent right on admission, that this can happen to you, this can happen to you, this can happen to you. So I know it is like, today's need because of the medical legal issues. But I don't know whether when she comes to us in OPD, then at 34 weeks, if we take that kind of consent, what mentally, whether she will be, I wouldn't be doing it routinely for all patients. Of course, those who are...
We have discussed, emergency management in detail. I just want to reiterate once again that taking consent for blood transfusion is another important thing,
yes, you have
which
to take
we
it
often
separately.
forget. Because it's a procedure, please take consent for every blood transfusion you are starting.
In our hospital now, we have a separate consent form for blood transfusion. Every time you have to give a blood transfusion, you have to take the consent separately for each transfusion. So that is absolutely mandatory.
Actually, we will say that, don't say that we are frightened and make you also frightened. So, Jyotsna, it is because patient, very vulnerable sensitively, and we say that it can happen, that fear really.
We are not vulnerable.
We are vulnerable, but we have.
I am only for doctors. I am only for doctors.
No, you are fine. And Ragini, what you say in document, medical legal, अभी आपने वीडियो टीवी की बात की, लेकिन मेरा मतलब जितना अनुभव है, in court only document, जो आपने लिखा है, that matters. It is like an income tax thing. What is in the paper, that will matter. And no, but like if we are very meticulous, कभी भी कोई patient serious होता है, it should be our back of mind कि ये patient can go either way, and keep the case sheet in the safe. It should not be इधर उधर पड़ी रहे, and make everything by the time if there is something good happens or bad happens, take your time when the patient is settled. हर legal point को हो सकता है आपने एक दो चीजें मिस भी की हो, but when you document it, please write everything what is totally evidence based. I am in this for doctors, क्योंकि बहुत सारी चीजें होती हैं, हम ये नहीं सोच सकते कोई चीज बिल्कुल perfect ही order में करेगा. But documentation and keep that case sheet safe, because sometimes the people take away case sheet and really it takes our all armamentarium. So be cool और अपनी सुरक्षा का ध्यान हमको रखना है.
And communication.
Chat box में Dr. Alka Kuthe, who is a very, very renowned medical legal consultant, she has written that there should be an antenatal education session where we should explain all these things in a general way to all the patient. I think it's we should all do this type of antenatal education combined session.
Yeah, general way is good. You can show the videos, you can show them that preventive aspects, that antenatal checkups are important, BP, anemia, so these can lead to complications. So that kind of education definitely is very important.
One more important thing for PPH is treating the antenatally anemia.
Yeah.
Maybe by IV iron, because checking the hemoglobin, and if patient, most of the more than 50% of the patients, they don't respond to oral iron because there is some problem in the iron absorption. And if she is not responding to oral iron, we can give parenteral iron so that she, at least we make her hemoglobin so that she is able to handle the blood loss.
And the blood loss.
Yes. Actually, here I would just like to highlight one thing, that many times we are thinking that patient is taking iron. But if you actually ask the patient on each visit, at times in front of her relative, she'll say, I'm taking iron. Because
we ask, what is the color of the stools? They say black, then you know.
In fact, otherwise only if you ask them, like, did they actually, or are they having any problem? It should be, the question should be framed in a way that patient should feel that there could be problem. Like what I have started asking now from my patient, because they were all lying to us that do you have vomiting or don't, is it that you don't feel like taking iron tablet? So many patients, they said, yes, if whenever I take, I start feeling nauseating and all. So actually, they may be taking just once in 3-4 days or once in a week, and they'll say we are taking. And they are very scared to say this in front of their relatives, because then it will be told, we told you to take it, why you have not taken it. So
whatever it may be, they also need parenteral iron if they're not tolerating orally.
That's what we have to identify patients there that actually they are having problem, and this question should be asked from each and every antenatal.
Timely intervention at around 30-32 weeks by giving parenteral iron, that will take care of anemia at time of delivery, rather than the patient presenting with 8
and anemia is a rampant problem in our country. Rampant.
We have to maintain at least 10 gram or preferably 11
Whatever
gram.
is the class.
If she is not thalassemia, target should be 12.
Yeah.
If she is thalassemia minor, it's okay with 10-10.5. Even
we should target 12.
Thalassemia patients also, they don't absorb iron 8 grams, they go to 8 and 9, and then you get an iron study done, and then you give you parenteral iron, and then they respond very well even with thalassemia minor. You get iron study, they are deficient in ferritin and this, and then they respond with parenteral iron.
And even small blood loss, they will not tolerate. That is also important. Sadhna ma'am, I was just highlighting that PG should know even a slight amount of blood loss in an anemic patient can be detrimental.
Yes, that's the basic hemoglobin will decide how much blood loss she can tolerate at delivery.
But
so we should
Promila,
target.
to say thalassemia, no parenteral iron, I think.
No, I have patients. I had 2-3 patients.
Your comment, because for thalassemias we don't really recommend.
No, their hemoglobin went down from 10.5 to 7. I got an iron study done. She was deficient in iron. She was not absorbing iron. I gave her IV iron, and with every time I got an iron study done, and
it will depend on serum ferritin level. Absolutely, it will depend on ferritin level.
Delivery at the time of delivery,
be less than 30
Otherwise, she was every visit she was going down 8, then 7.
No,
then
I think serum ferritin is very low. Then below, mostly if it is below 10, then the
without serum ferritin and serum iron study, we don't give parenteral iron.
We will not give. We will give it very strictly.
I have given in 2-3 thalassemia minor patients with iron study, and they responded very well. We avoided blood transfusion at delivery.
Like
Dr.
patients with
what you
severe
want to
anemia, many patients
Dr. Jagsonpal want to say something.
No, I didn't. I was just responding. Dr. Sadhna ma'am was asking. So yes, I also have given to few patients of thalassemia minor after documenting that they are iron deficiency anemia. If they have severe deficiency, then our hematologists are also advising that we can give. But of course, they also say that first you try to give oral. Give them, if they have time, you give 2 weeks of oral. If they are not responding, then we will give IV. But yes, in a couple of patients we have given.
Shashi, what you are saying?
I was just saying, when many patients with severe anemia come to our hospital in late trimester, like 38 weeks, 39 weeks, 37 weeks. So if we build them up, give 2 to 3 blood transfusions, and then deliver after making hemoglobin at least 10, I've seen that maternal mortality has decreased drastically.
Yes.
And given the incidence
of
absolutely.
So I think very, very fruitful discussion we have today. Thank you so much, all the esteemed panelists who has joined today, and all the delegates who has given their time. So Jyoti, over to you for the vote of thanks, and we will.
And we want to wish Dr. Sadhna Gupta, madam, And
yes, ma'am. Yes,
all our best
all
wishes.
our best wishes to
Thank you.
Yeah.
Thank you. Thank
I also need your wishes, Ragini ma'am, Sadhna ma'am,
And everyone.
And we wish
Shashi.
Dr. Anita also, even
Thank
though
you.
we are not there to vote for you. I mean, I am not the.
No, your blessings are required.
Are there, but I am not actually going to. I don't have the power to vote for you. So.
And the Mala also.
Mala, yes.
Mala also.
Yeah, Dr. Mala also, definitely. We wish that all our Delhi people will win with laurels, and we have very, very special wishes for Dr. Sadhna. She's like part of her.
Thank you.
Thank you. So,
thank you, Ragini ma'am.
Thank you, everybody. Thank you, Dr. Sadhna ma'am, Dr. Shashi Lata, Dr. Mala, Dr. Anita, Dr. Jyotsna, and Dr. Rekha. All the drills were super. PPH drill, the eclampsia drill, and the maternal collapse. So, and so many new points that have come in small new points that everybody could grasp. That was wonderful. And I thank you all on behalf of HARObGyn that you could convey so much of your practical information to all the attendees. And on behalf of HARObGyn, I again invite you on Sunday. We'll start right at 9:30, and the whole day is a rigorous maternal, how to prevent maternal death. So the heads from all over Haryana and in Delhi and India would join on this platform again on Sunday with Jagsonpal and many other pharma partners that are joining in to support this Save Mother program. And thank you everybody for today's program. We hope to see you again on 9:30 Sunday morning till 5:30 in the evening. Thank you all. Over to
India सुनेगा
Ankit.
तभी तो patient बचेगा.
Thank you.
Dr. Deepika.
Thank you.
Yes, ma'am.
Thank you so much. And my teammate, Mr. Ankit, is here.
Very good evening to all the faculty, esteemed faculty, and attending doctors. On the behalf of sales teams of Jagsonpal Pharmaceuticals Ltd, I, Ankit Dogra, from Medical Services, seek your supports for our products. LycoRed soft gel capsules containing world process patented complex Lycometo, the all-natural extract containing lycopene along with zinc and selenium. We also present Cystelia M tablets formulated with the ideal 40:1 ratio of myoinositol and D-chiroinositol with folate and vitamin D3 to restore the reproductive health in women, and LycoRed Preg sachets of L-arginine, lycopene, and DHA for high-risk pregnancies. Our sales team visiting you is continuously striving to make your bulk purchase experience effortless and worthwhile. We thank you for this opportunity to connect with you today through this webinar and looking forward to your support to our brand in our product portfolio. We thank you for your presence today, and please join us tomorrow at 5 p.m. for a webinar on umbilical cord organized by ISOPA Prayagraj. Please note down the Zoom ID displayed and register now. Thank you very much.